remarks. Over to you, Ren.
Thank you, Gordon. Distinguished STAC NTD members, representative of partner, dear colleagues, friends, greeting from Geneva. It's my great pleasure and honor to welcome you to the 16th meetings of WHO Strategic and Technical Advisory Groups for Neglectable Disease, or STAC NTD. I especially want to welcome new members to these advisory groups. I'm confident that you will bring a host of new ideas and fresh thinking to this group's deliberations. The NTD department is in a transition, following the death of our late most esteemed director, Dr. Moeedi Malasala, in February, and the enormous departure of its interim head, Dr. Gaudenz Biswas, who will retire at the end of September, after 23 years of distinguished services to WHO. The search of new directors is underway and is likely to be completed soon. In the interim, to ensure the continuity of the department's annual work plan, Dr. Rama Walinuddin will perform his duties of director. I deeply thank Dr. Gaudenz Biswas for his great contribution to BEAT NTD and welcome and congratulate Dr. Rama Walinuddin and looking forward to working with him in his new role, as well as with you all towards the goal of eliminating neglectable disease. I hear some notice right now. I don't know where it is. If okay, I will continue. It's under such changing environments that we particularly value the essential nature of the advisory bodies such as STAC NTD. Your recommendations are vitally important to us and will continue to keeping us focused and on the track. Despite this changing time, WHO continues our work with the same commitment as ever, and will continue to make progress in countries, and the most recent being the elimination of trachoma as public health problems in Malawi. However, your discussions in the next few days will focus on critical issues of the recovery of NTD services at the country's level following the disruptions caused by COVID-19 pandemic. COVID-19 has severely impacted many health services, including NTD activities worldwide, depriving millions of people's treatment of care. The programs has been adapted and strategically has been moderated to contain this damage. We'll learn more about the mitigation of disruption of essential NTD services during the meeting, and we look forward to your advice on the best to move forward. The landscape of global support NTD programs has also changed due to COVID-19. One of the outcomes has been reprioritization of commitment. We need to better understand what has and is happening, the reasons behind these changes, and how to ensure our act properly in response. Our priority now is to ensure the gains made in the fight against NTDs are not jeopardized by the COVID-19 on one hand, and by the shift in global support on the other. We must ensure that the goals and the milestones set in the NTD's roadmap for 2030 do not get off track. Your guidance and advice are essential. So I'm looking forward to receiving your recommendations this meeting. I wish you full discussion, deliberation, and very productive meeting. With that, thank you very much. Back to you, Gaudenz. Gaudenz, back to you.
Can you hear now in the breakout room?
Yeah.
Yes,
I can hear you.
Okay. So I think so. Thank you, Dr. Ren, for those piece of advice. I'm pretty sure the members have taken note of it and will follow. So just before I give the floor to our chair, Dr. David Mabe, just a couple of words. I think since the last version you might have seen of the agenda that we circulated, we have made a little change, and this time we have it actually invited some of our partners who have been doing so much work in the field to share some of their small ideas and thoughts. And so we have carved out the session from your lunchtime. I hope you don't mind, because the value of those presentations would be really worth it to see and listen to. So with those words, over to you, David. Maybe if you move to that one, then I think we can handle this. Sorry, if you move to the next. This. Yeah. Just move to this. So. Sorry, I asked. Uh, works. This is the this.
Okay. Can you hear me? Can you hear me? Yes.
Yes, yes.
Okay, thank you very much. So my name is David Mabey. I'm at the London School of Hygiene and Tropical Medicine. It's very nice to see colleagues again face to face. It's been a long time. And I'm very much looking forward to meeting many new members of STAG who Gautam is about to introduce. So administrative matters, I think the most important one is to identify a rapporteur. And for our last meeting, we had an excellent rapporteur, which was Lucille Bloomberg. And I'm delighted to say she has agreed to be our rapporteur again. So thank you very much, Lucille.
I'll do my best.
So I don't, any more administrative matters that we need to discuss?
I think, Linda, if you have any administrative matters, do we have to wear masks, not wear masks? What do we have to do?
Well, in principle, due to the capacity of the room, we should all be wearing masks. So I've left masks there, let you know decide what you want to do, but normally the future rules and regulations are, you know, decide with this amount of people, we should all be wearing masks. Do you have any other administrative for the moment?
Well, I don't think anything for the moment. We have a breakout room in the D building, because we, as you can see, this room is a little small. Those who have been coming to the previous stags, we used to meet in the main building and big meeting rooms. Unfortunately, that building is closed for renovation, so we couldn't access those rooms. So we had to manage in this small place. I hope you wouldn't mind, but we have made provision for another room, which is the breakout room, and many of our colleagues are there. We have actually tried that most of the partners who have taken the effort to come here have a place in this meeting along with the STAG members. So, and again, Chantal and Linda are available if there are any issues, administrative issues. Please reach out to them, and they will do their level best to sort it out. So, yeah, I think we can continue. So we go to introduction of the new members.
I think that's over to you, Gautam.
Okay.
Yes, please.
Okay, thank you, David. As you know, we had in the past, the number of members had shrunk down to 9, and also within that, Dr. Steve Lindsay resigned because he had retired from his service, and he didn't and very politely wanted to excuse himself from the STAG. So we are down to 8, and I think, as in support of the roadmap, we believe that we need to have a much bigger STAG, And now the STAG and all these advisory groups are kind of regulated or guided through the science division to ensure that the members and there is no conflict of interest and other things. So we had asked and given an open call for people who would want to become members of the STAG in June. We had a very good response. We had received over 130 very excellent scientists from across many fields, not only NTD, but health systems and other things. As you know, the roadmap is now much broader in nature and talks of mainstreaming and other things. So following that, and it's a difficult process of selection, we have to ensure that there is adequate regional and gender balance in the group, ensuring that the excellence and expertise is all there. So 12 new members were selected. So we currently have this tag. The total members here in the room as well outside is, I think, 22 now. And then at certain stage after this meeting, some of the members, because of the rotation, will go down and we will end up with 17 members. So I think that becomes a very good, strong core group for the STAG. And I would take this opportunity to invite the new members or the members of the STAG, starting with the new members, to introduce themselves to the group. I think we had a short informal introduction over virtually, but this is to the larger group of all the partners. So can we just go around from there, introducing yourself, the new members of the STAG?
I'm Dr. Indivari Gunaratna. I'm a medical doctor and a public health specialist. I'm working for more than 15 years in public health, and I have experience in vector-borne diseases for more than 10 years. I have been working with malaria program during the elimination phase. I'm from Sri Lanka, and now I'm working with lymphatic filariasis. I worked in dengue control program also. I'm working as epidemiologist, statistician, as well as I'm specializing myself in medical entomology and applied parasitology. And I have a good experience in strategic developing strategies and monitoring evaluation, surveillance, and those kind of things. And we have another few MTDs in Sri Lanka. We are facing leprosy, leishmaniasis, and rabies, and we are also developing our strategies toward reaching elimination status. That's it. Thank you.
Okay, sorry, can't see very well who is placed where. So you just identify the new members, please, who are here in the room. Yes, please go ahead.
My name is Wande. As you know, Ethiopians were named by our first name. I'm a professor of dermatology and a global health specialist from Ethiopia. I've been working. Is there something? Is it audible? Okay. And I've been working especially on skin entities for the last 15 years. And recently, in the last 5 years, I'm working clinical trials on STH and other entities. Thank you.
Thank you. Yes, please.
Good morning, everyone. My name is Vũ Quốc Đạt. I'm an infectious disease physician from Hanoi Medical University in Hanoi, Vietnam. My experience was focused on the management and treatment patients with dengue and other tropical diseases, and my research focusing on the infrastructure capacity evaluation and also strengthening the capacity in diagnostic of the fungal diseases. Thank you.
Okay. So all the new members present in the room have identified. Okay, please go ahead.
Good morning. My name is Judd Walson. I'm an infectious disease physician trained in pediatrics and adult internal medicine at the University of Washington. where I'm a professor of global health, medicine, pediatrics, and epidemiology. My experience primarily focuses on enteric infections, nutrition, and child survival, but I have a strong interest in a number of projects related to soil-transmitted helminths and other NTDs, and I primarily focus on large multi-country clinical trials to generate evidence for interventions. Thank you.
Thank you. What I suggest for logistics reasons, because the rest of the new members are online, maybe I think we should go around the existing members who are in the room, starting with Margaret.
Hi, good morning. My name is Margaret Japong. I work with the University of Health and Allied Sciences in Ghana. My background is in medical anthropology and health systems. Thank you.
Thank you. We'll give a minute to Dr. Gabriel. We're going through the introduction. Dr. Dhariwal.
Good morning. I'm basically public health specialist and worked as director, National Center for Disease Control in India. Handled visceral leishmaniasis, lymphatic filariasis, malaria elimination, and soil transmitted helminths. And we were lead in yaws eradication program in India. We succeeded in getting the yaws free status sometime in 2016. Thank you. Over.
Okay. Can we come on this side, Dr. Lee Ching?
To press this. Hi, I'm Lee Ching from Singapore National Environment Agency. So we work on infectious disease of environmental concern from the environmental perspective. So this includes vector-borne diseases like dengue, Zika, and even from aspect of COVID. From the environmental perspective, we do investigation and risk assessment. Thank you.
Thank you. Can we go to Dr. Bloomberg?
Lucille Bloomberg, National Institute for Communicable Diseases and the Veterinary Faculty in South Africa. I'm an infectious disease specialist, microbiologist. My main interests are pandemics and epidemics and emergencies, but for NTDs, it's trypanosomiasis and rabies. Thank you.
Thank you. Dr. Salahuddin.
Hello, my name is Dr. Naseem Salahuddin. I'm a specialist in adult infectious diseases at the Indus Hospital and Health Network in Karachi, Pakistan. Among the many other NTDs of my interest, my focus is on prevention of rabies all over the world, but particularly in Pakistan. Thank you.
Thank you. If we have covered every member, new and old, okay. Yes, Doctor, please go ahead.
Good morning. I am Rosa Castalha. I am a medical doctor specialist on public health from Brazil. I am used to be the former coordinator for leprosy and NTDs in Brazil. And now I am in the Department of Global Health of the University of São Paulo, and in focusing on NTDs in the global health perspective.
Thank you. And yes, please go ahead.
Good morning. My name is Gabriel Parra Henao. I came from Colombia. I am biologist and I work in the National Institute of Health. My main focus is in the control of vector-borne disease. I have been working in integrated vector management and the control of Chagas disease. Thank you.
Thank you. So now I suggest we move to our members who are connected virtually. Joy, how do we give the floor to them?
Call them out and
Can you call them out, because I don't see the names. Hmm? Yeah, it's difficult for me to. Yeah, ask them to just open the mic. Okay. The two things I would suggest for sake of the benefit of everyone who is online, those who are online, and if you are a STAG member, can you rename yourself and add as a STAG member in addition to your name so that those who are looking at the list can see you as a STAG member, identify you as a STAG member. Similarly, those who are partners and others who are online, if you can just write your designation, that from where, so it is a little easier for everyone to identify everyone.
I think I can call the.
Yeah, go ahead, Elvis.
So
Ahmed.
Dr. Ahmed Abdul Wahid.
So, hello everybody. Here is Ahmed Abdul Wahid. I am the lab head of the Institute Animal Hygiene and Veterinary Public Health, University of Leipzig, and I am a veterinarian by training, and my research focus on novel diagnostics or mobile molecular diagnostics for emerging and neglected tropical disease. So that's it from my side. Enjoy the meeting.
Thank you. Professor Olaoluwa Akinwale.
Good morning, everyone. Sorry, I'm still in the traffic due to road construction. I'm Olaoluwa Akinwale from Nigeria. I'm a parasitologist by training, a professor of parasitology, and director of neglected tropical disease research in the Nigerian Institute of Medical Research, Nigeria. My focus is on schistosomiasis and more recently on Buruli ulcer. I'm very happy to be part of this meeting. Thank you very much.
Thank you. Professor Marcus Boulos. He's not online. Dr. Niraj Dhingra.
Good morning to all of you. It's a pleasure to be part of this group. I am a public health specialist with nearly 30 years of experience in communicable disease, mainly on vector-borne diseases like malaria, and recently in the last phase of my working at National Center for Vector-Borne Disease Control. I was involved in visceral leishmaniasis elimination and strategizing for MDA, and also for looking into smaller IUA and implementing units. I also have been engaged with leprosy also in India. I look forward to active participation in these meetings. Thank you.
Professor Heather Ferguson. She may not be online actually. She's not online. Okay. Dr. Ala Hamid.
Good morning, everybody. My name is Ala Hamid. I am a former World Bank staff and was a team leader for Egypt, Yemen, and Sudan. And as part of my work, I was leading the World Bank finance projects for the control of schistosomiasis in both Egypt and Yemen, and also a program for a technical assistance for NTD for Sudan. I am from a health system background and interested in integration of NTDs in the system service delivery mechanism. And also I have more of a cross-cutting work related, not only work on health, but also I work on population, nutrition, and social protection projects. And I'm very happy to join the team. Thank you very much.
Thank you. Dr. Oscar Daniel Salomon.
Good morning, everyone. I am Oscar Daniel Salomon. I am director of the National Institute of Tropical Medicine of Argentina. My professional background are biology and epidemiology, and my main fields of activity are operational research on ecoepidemiology and social determinants of vector-borne diseases. Thank you.
Thank you, Dr. Susanna Vasneri.
Hi, everybody. Nice to be here, even if it's really far from you in Geneva. So I'm an associate professor at the Kirby Institute, University of New South Wales, Australia, Sydney, where I lead the neglected tropical diseases research group that uses intervention studies to generate evidence that can inform health policy changes for more effective disease control. Entities of interest in my group include STH, schistosomiasis, trachoma, scabies, yaws, and more recently onchocerciasis. I'm originally from Portugal and started my career on tropical diseases at the London School of Hygiene and Tropical Medicine 18 years ago. I did some international development work as well, and lived and worked in multiple African countries, and rejoined academia 10 years ago, having moved to Australia a bit more recently. And now my research also includes countries in the Asia Pacific region. Thank you.
Thank you. That's all. Gautam, back to you.
Okay, so have we completed the introduction of all the new and old STAG members who are either in the room or online, or have we missed anyone? Yes, please. Can you use the mic, please? There's a button to push. Yeah.
Okay. I'm sorry I was late. I'm Anna Giné. I'm the research coordinator at ANSPAD Foundation, and my background is in public health and medical anthropology. I also work at the University of the Basque Country.
Thank you. So I think, David, we have completed the introduction of the new as well as the old members, and all their brief CV is now available on our website. So those who would wish to have a look and meet them and have more details. I would have liked to have everyone introduced, but with the shortage of time, I would suggest, if you're in agreement, that if anyone who is taking the floor at any time introduces himself or herself. So if that is acceptable, then
yes,
back to you. Good. Yeah, back to you then.
So the next item on the agenda is the year in review from Gautam Biswas, and we were sent some pre-reading material, 103 pages, I think, report, which I'm sure we've all read carefully. And Gautam, I think, is going to summarize that for us.
Yeah. So, David, we were actually testing the motivation level of all the members to, to see, how much you read. Well, I think the idea was that when we make these presentations during the STAG, if there is a background to it, and again, the expectation was not that every one of you would have read line by line, but maybe your areas of interest you would have picked up, so that during the discussion at the STAG, there is a background to it, and it is not just from the presentations that we are making, because the presentations are short. We try to make them short, and we should just leave the essence of the following discussion. And as you know, if you see your agenda and what we have, we are trying to focus this meeting on recovering from COVID. I think COVID has hit, as Dr. Ren mentioned in his opening speech, has touched probably every health area, not only health area, other areas also, but especially NTDs, and that we would like to highlight. And in my presentation, again, this presentation is the work of all the three levels of the organization, whether it is headquarters, regional office, or the country office. While there will be more presentations kind of getting into details of that. So it is kind of a summary of, can we have the first outline? So what I would do is try to complete my presentation with the outline that we're talking of the overall progress and achievement. Next slide. Yeah, overall progress and achievements. I also want to highlight the fact that when we talk of entities, we are always talking of endemicity. So there is an outbreak aspect to it, global health and technical products. I want to introduce this topic because it's becoming very important when we frame our work and talk about what we have done on the previous TAG recommendations, the working group updates, and various NTD events, and end with some challenges that we find. Now, next slide. So if you recall the NTD roadmap, the roadmap has, again, there are indicators and there are 4 overarching indicators. And one of the first one is also the SDG indicator 3.3.5, which is a number of people requiring interventions against neglected tropical diseases, with the goal is that by 2030, we would have reduced these number by 90% as compared to 2010. So if you see the graph, substantial progress has been made from 2010, from 22, almost 2 billion people, a little over 2 billion people, to 1.6 billion by 2021, and this is a 24% decline. So there is still a long way to go. And again, if you see this indicator, this is a very composite indicator of progress against all of the diseases. Some of the diseases contributing a large part for this indicator, mainly those where the large-scale chemotherapy are happening, but it includes also individual diseases. Next slide, please. Okay, the second indicator is a 75% reduction in the DALYs. And this was, if you recall, those who participated in the roadmap, the importance of reducing the disease burden. So again, it was an impact indicator. And if you see the DALYs, unfortunately, DALYs that are available don't cover all the 20 diseases. Presently, only 14 diseases have a DALY value to it. So there is work to be done to see how we can increase the bring the other diseases in and have a DALY calculation to that. And also, we have also heard that the DALYs that are associated with the existing NTDs may not be appropriate. There are little value of burdens that the different weights associated are, and this is a part of the ongoing discussion. But whatever it is still a number, and you can see from the 14 NTDs which have a DALY value, there is a regular decrease since 2005. Now, in the roadmap, the target is 75% starting from the roadmap year, but the most recent at the time of the roadmap was 2015, and then we have the 2019, which is roughly an 11% decline between the 2 years. Next slide, please. The third overarching indicator is the target of 100 countries should have eliminated at least one NTD. I see this slide might be a little busy for you to see all the numbers, but basically what it shows is that 46 countries have till today eliminated at least one NTD, and some of them even more. Togo being the only country which has done 4 of them, and this was acknowledged in a recent Afro-Regional Committee meeting, but there are many with 3, 2, 1, and things like that. The goal is 100 by 2030, and so there is still a lot of work to be done on this. Next slide. And just to remind you, the country is counted only once. Even if it eliminates more than one disease, it's still counted as one. So, and this is, if you see the evolution in the last 5 years, and even in the COVID years, 2021, you see we managed to, many of the countries came forward with their claims for elimination. And in 2022, Saudi Arabia for trachoma, Rwanda for Gambian sea hat, Uganda for Gambian sea hat, Togo for trachoma, Equatorial Guinea for hat, Vanuatu and Malawi for trachoma. And as Dr. Ren said, Malawi was the last one that we've done. Next. This is a quick snapshot of few of the diseases, again, where you can see that there is a 78% decline in visceral leishmaniasis as compared to 2010, 68% decline in blinding stage of trachoma since again from 2010. Then guinea worm, which is slated for eradication, reported 15 cases in 2021, and this year we have till now only 6 cases. Buruli ulcer, again a 66% decline since 2010. Gambian sea hat, 89% decline. Leprosy, 40% decline. So all these diseases are making substantial decline. But again, we have to look at the entire 20 disease landscape, which is something that we have to think in the future. But having said this decline, I mean, we have put a note below is that, leprosy, Buruli ulcer, hat show an increase in detected cases after the 2020 drop. And this is basically due to the COVID-20 disruptions. Next slide, please. So this is again a chart which shows the number of individuals who have received at least one NTD over the years. And if you see till 2019, we have had an increased trajectory with over 1 billion people being covered. Unfortunately, 2020, we have a 34% drop to almost 800, with some recovery being seen in 2021. So again, this is the impact of COVID-19 disruption. And again, there will be further discussion on the COVID-19 disruptions, and you will hear more on these as we dissect this further. And the preventive chemotherapy or the large-scale chemotherapy was one of the main areas. Next slide, please. One of the areas which also was mainly affected. And if you again see this, we have broken down by different target diseases from left to right. Is if you can't see the legend in the x-axis, starts with lymphatic filariasis. Again, you see 20 and 2021, there is a significant decline from almost the 65% target coverage that lymphatic filariasis was achieving by 2019. Onchocerciasis, some decline in 2020 with some recovery in 21. Soil transmitted helminths and trachoma decline in 2020 with substantial recovery by 2021. Schistosomiasis still declined in both 20 and 21. And if you see overall preventive chemotherapy, the similar impact. So these have been the, it's if you remember when we had the last stag, we didn't have these numbers. We were talking of the impact, but these are, and again, I remember questions being, okay, so what happens in the field? So you can clearly see that these are, this is the impact. And again, when we go into details, this is a global picture. Of course, countries have performed differently. Some countries still struggled more. Some countries were still working better. And if you go down within the country also, it has been a heterogeneous kind of impact of COVID. Next slide, please. This is where I wanted to highlight the fact that, NTD is not just an endemic disease. There are many of the NTDs which are bound to have outbreaks and including deaths at some times. So, we have tried to identify some of the outbreaks that we have faced since 2020. So the countries in yellow are the VL outbreaks. Then we had scabies outbreak. Dengue was another disease which had multiple outbreaks across 21 and 22, and including chikungunya in Chad. So the idea was to highlight this fact was that we also need to have a response for the outbreaks, and we are working very closely with our colleagues in the health emergency. Next slide, please, to oversee these outbreaks. So we gradually move to the area of cross-cutting activities, and this is in relation to vector control of Global Arbovirus Initiative, which was launched on 31st of March 22. And if you see, this is a 6-pronged attack, and also talking with urban health and sterile insect techniques that have been introduced towards the vector control aspects. Next slide, please. So there has been some collaborative and country support activities with capacity strengthening of 8 GLP compliant laboratories to ensure that the testing, there's adequate capacity to test the vector control products. And there has been multi-center studies for insecticide resistance monitoring. The VCAG has been an active group which is looking at new vector control tools. And as far as country support is concerned, training on vector control and insecticide resistance monitoring has been carried out in many countries. And in the GVCR implementation, this is a global vector control response implementation, the joint action group to coordinate among headquarter and regional activities has been in action. And at some point, I mean, if you wish to have more details, Raman could expand on that. The next issue is the One Health. Next slide, please. Yeah. So again, as you know, the roadmap puts a lot of emphasis on these cross-cutting activities and including One Health. So a roadmap companion document on One Health and NTD was published. A guide to introducing human rabies vaccine into national immunization programs was also published. And there has been now a new donation for extending the donation of albendazole to cystic cysticercosis. So thank you, our colleagues in GSK. First ever target product profile for snake antivenom products in sub-Saharan Africa was developed, and an information platform has been launched in September 2021 for WHO for snake bite information. Skin NTDs was another area that the roadmap had highlighted, and again there has been some work that we have carried out, including bringing a integrated skin NTD strategic framework that has been published as a technical product, and I'm using the word technical product and I'll explain what that means. Advocacy and technical work has been carried out to move the agenda forward with several countries in different geographical areas. And now support is available by several partners and donors in the area of integrated skin NTDs. And technical product profiles have been developed for diagnostic tools for Buruli ulcer, dermal leishmaniasis, mycetoma scabies, and yaws. Okay, so let's what I thought was I would give a little brief on what in WHO we call as technical products or global public health goods. And this is something that is now part of our work plan. And, it is no longer for departments to just come up with what they want to do. There has been a process to identify what these things are. And if you see, overall, we can divide our functions into leadership functions, country support on the other side, but in between is the technical products, or previously which we called global public health goods. So these are products which are applicable to multiple countries, developed through a very rigorous process at global, regional, and country level to drive an impact. And they could be norms and standards, they could be around data, and they could be around research, innovation, and horizon scanning. And there are some accompanying adaptation and derivative, basically accompanying documents are, so there is a core technical product. Around the core technical product, there could be accompanying documents, which means that it's a related product with some change in the technical guidance in that. Adaptation is when you are adapting the core product for regions and others. And derivative is mainly the same product without any change in the technical product, but maybe translations and others. So next slide, please. So again, this it goes through a criteria, and the reason why I am sharing this with you, because there is a role of STAG in these. I mean, the STAG and advisory bodies can be useful in shaping these technical products. So there is a must criteria, which is that it must fill a need that has not already been filled by an existing technical products to avoid any duplication. And this is across the organization. So these are scanned from all departments to ensure that there is no duplication. And then it must meet one of the other criteria, that it should respond to the country needs and meet the objective of the 3 billion. WHO has a 3 billion goal as part of the general program of work. So it should be linked to that. or it should have been called by a general body resolution, or it should be linked to an evidence-based emerging global or regional health issue reflected and demonstrated by different groups, including groups like the STAG or Partnership Forum. And again, next slide, please. It goes through a process of a three-level process, three stages. The important thing that I want to highlight is that it is every product is reviewed across the three levels of the organization. And then it is what we call as 10 is a technical expert network. So it is one area. So we have NTD across the three levels, which review them for its need. Then there is an ODT, which is an output development delivery team across different departments. So that reviews, and then an independent TP leadership committee, which reviews. So the idea that I want to leave behind with you is this is a very robust process that the organization has taken for identifying the technical products. The key is that these should be meaningful and useful for the countries. And the other aspect that is highlighted is it is not enough to just create the TP. It is important that this TP is then implemented at the country level. Unless that happens, the value of the purpose of the TP is not solved. So this is a kind of an end-to-end process that we are talking about. Next slide, please. So just to give a flavor of the TPs, and this is actually taken from the WHO Central Repository of all TPs for NTDs. And if you see for 2021, we had 11 agreed technical products, or that year we used to call them global public health goods. 7 of them have been completed and published, 4 are still in the progress. And then there are the next 3 bars are basically the supporting documents, or the ones which are derivative products, translation and other things. So out of 41, 21 have been published and 17 are in progress. For 2022, this biennium, the 2 years, we have 17 agreed and planned products, and out of that, 1 is in progress. And you can see all the other products. Now here, I think I'll just mention one part. You might ask why only 1 in progress out of 17. It only gets ticked in the database when we send a planning. There are 3 stages. A planning process, we submit a planning which ensures that how is the TP going to be developed? Who are the people who are going to be involved? How is the independence and science behind it emphasized? So that goes through a quality assurance process. But even before that, the department starts working on it. So all out of the 17, many of these, we are still working on it, but we haven't yet made the planning clearance from the QNS. So as the year goes by, this number will increase. So some of the outcomes of this this activity. Next slide. So again, many of you would have seen them. The roadmap itself was a technical product, but the associated documents were the associated products. And the last one, we have an accompanying document on the. It is basically to support the funding. I'm forgetting the title and I can't read it, unfortunately. There, it is the justification for continued investment in NTD, and the reason why it was important. It will be very apparent during the course of time. The next slide. The other important outcomes of these technical products has been 16 target product profiles that have been developed. Again, this was also as per the recommendations of the STAG on various disease and overseen by the Diagnostic Technical Advisory Group. Next slide, please. Okay. So as I said, one is to develop these technical products. The second is that how do we ensure that the countries where it is used have the capacity and the know-how and the knowledge to do that. And I would say somehow the COVID-19 2 years that we got disrupted may be a blessing in disguise to these online courses. because we had no way to have physical courses and material. But what we did was WHO now has an open WHO platform, and an NTD channel has been created on that, and there are a number of courses, a total of 33, I think now. Many of them are one course in multiple languages, but it covers many areas. We'll see in the next slide. And I think number 50,000 learners have now enrolled onto these different courses. Next slide. So these include online courses on the roadmap and safety in administering medicines for NTDs. Again, if you see, they're all somehow linked to the TPs. So there was a technical product. So now through the online courses and other things, the idea is how, ensuring the users know how to use them and really use them. Next. Okay, these are some other online resources. So we have through mobile apps, the roadmap is available as a mobile app. The integrated skin NTD has as a mobile app, and it has gone through many iterations. We have even collaborated with the Netherlands Leprosy Relief, who were also developing on the app, so it was merged. Then we have had so many webinars. Many of you have participated in these webinars on various aspects, both advocacy as well as technical aspects. And all of these are available on YouTube channels for anyone to see. Next. Okay. So let's move to a bit to the access to medicines. Again, a very important component. Even in the roadmap, this is highlighted as one of the 4 gaps. And again, I would like to thank all our pharmaceutical donors who have been continuing to support this through donated medicines. And recently we had Bayer, GSK, Eisai, and Janssen renewing their previous commitments through new 4 or 5 year agreements. Next slide, please. So why do we benefit from the generous donation of medicines? Not all medicines are donated, and it is very important that the quality of the medicines, whether they're donated or they're purchased by countries, are good. And this has been an area that the working group on access to medicines and our colleagues in the PQ have been working on to pre-qualifying medicine, so that countries who are buying medicines, the medicines which are not available in the through donation, can access good quality medicines. At the moment, we have 10 NTD medicine in the pre-qualified list, and there is 5 still pending. Recently, 3 on albendazole, 2 on praziquantel. And in addition, those who do not make to the pre-qualification have a expert review panel where it's an annual year-to-year kind of quality assurance is provided, so that countries can still access these. Next. So this is the, again, from the country support part, this is how we as WHO are ensuring that access to donated medicines are available to countries. And if you see, the scale is in millions. So it had peaked in 2019 to almost 800 million units of medicines or tablets have been provided free of cost to different countries. Unfortunately, again, this is a reflection of the COVID disruption. In 2020, the number got down, and 2021 is also less, because there has been a lot of carryover of medicines which have not been used due to disruption of treatment cycles. And 160 countries, we peaked to 160 countries. So this is a big part of the program that WHO does to ensure countries have access to good quality medicines that are donated. So next, I'll just briefly go through the various STAG working groups. just an outcome of the various working group. This is the newest one, which was set up. And I think this STAG working group on access to safe, efficacious, and quality assured health products for NTD ensures is mainly working on the, as you saw, the quality assurance of the medicine products, but now they're also struggling to ensure that the diagnostics have a quality assurance. So that's again something that the STAG had recommended in the past. So that's the work being going on. We have the monitoring, evaluation, and research working group. And one of the main products that this group had facilitated was the M&E framework. And subsequently, the work of this group has been focusing on ensuring the definitions of the various indicators so that to avoid ambiguity and standardization. It is now going to be released as a NTD compendium. I'm hoping that the compendium will be out in a couple of weeks. I think we have cleared that. Then there is a working group on capacity building. This is mainly an internal working group and has been, very instrumental in ensuring creating the content for the various online courses which are now available on the Open WHO channels. And again, we also carried out a global online survey along with our colleagues of Open WHO to see what was the need that the community had. And surprisingly, most of the need that they expressed was on the roadmap implementation, cross-cutting aspects, One Health, and of course there was disease-specific ones. But these were also it was good to see that people are thinking much broadly and are looking forward for having receiving some guidance on that. Okay, next. Okay, so we will just I will kind of scan through these STAG recommendations. Just wanted to assure the STAG that each of your recommendations, we take it seriously, we follow it up, and some can be immediately sorted out, some takes time. And again, if you recall the 14th meeting of the STAG in 22 to 24 June 21, I think the areas that have been working on is the VL in Africa and Americas, rabies in Africa, Eastern Mediterranean, and echinococosis and cysticercosis, mental health and NTD. I think there has been a joint publication on that. Post-market quality assurance on insecticide products. I think that's also something I discussed at the beginning. Then greater attention to assessing the burden of NTDs. This is an ongoing process. Measures to mitigate impact of COVID-19, avoid expiration of medicines. And I think the good news, and we will probably hear it much more in detail later in the presentation, is millions of tablets could be saved because of reshipping from one country to the other to avoid them expiring because of non-use. And again, we are trying to mitigate how to, the funding cuts that unfortunately we have, the program has been facing both in WHO as well as the countries. Intensified efforts in control of the last mile stages and finalizing the dossiers for guinea worm. And happy to state that the DRC is now, I think the international certification team has already visited, evaluated that dossier, and support to Sudan is continuing. The additional STAG entity meetings are a reality now, so we always have a virtual meeting in between the face-to-face meetings. I hope we will continue that, Chair. The 15th STAG meeting was mainly focused on the diagnostics for NTD and their quality assurance, and then the visceral leishmaniasis in Africa and Americas. I think I'm not going to go into each of those things, but just to assure everyone that we are taking the kind of action that you have expected us. Next slide. I come to one issue which I think you need to have in this STAG as lead for information, which probably you will have to act in your subsequent meetings. And this is the adding diseases to the NTD list. I think every of the meetings, this issue has been discussed in some form or the other. And you have very rightly so, we believe, set a moratorium that you will not review any new or additional diseases till 2023, which is actually next year now, with the idea that it was that there is a lot to be done on the roadmap with the existing diseases before one could take new ones. But in the meantime, there is interest, of course. There is a need at the country level for diseases that is expressed by the countries in the assembly. So one of them is NOMA, and NOMA has been it has been a World Health Assembly resolution to review NOMA and to consider it to be a neglected tropical disease. But of course, as you know, the decision and recommendation comes from this group. But our colleagues in non-communicable diseases, irrespective of the decision, are continuing to develop the guidance, and also the African regional office has been working on to providing support to the countries on NOMA. But we believe this will. We have already received letters from Switzerland. Nigeria is very keen and is following up with providing a dossier. So you should be expecting soon a dossier, but this is also a guidance that we would like to hear from you, how we prepare with the next tag or which one for this discussion. The second aspect is that we have also been asked by some of the countries or some of the groups to have some clarification on some of the disease groups where we have said scabies and ectoparasites, and they want us to define what the ectoparasite is or are. The same thing is with deep mycosis. So I think in the next tag we will be providing you with our position on this, what we believe should be considered for your review and further recommendation. So then I would come to some of the global NTD events. There has been two events. One is the celebration of the World NTD Day and the World Chagas Day. These are the 2 days which are officially WHO days. And then in addition, there are other days that also we celebrate with our partners. And there are some very significant events that has happened in 21 and 22. So one was the interest that the what they call as group of friends. These are ambassadors of countries in New York who work with the UN, and they have created a group of friends on defeating NTDs, and they are very keen to support from the political angle the aspect of NTDs in the UN. The second was the Abu Dhabi Declaration, which was the last mile issues with guinea worm disease eradication. And on 23rd June, on the sidelines of the Commonwealth Heads of Government meeting in Kigali, our colleagues from UTC, Rollback Malaria, and Malaria No More organized the side event Kigali Summit on malaria and NTDs. I think it was a very successful event. You can see Prince Charles then Prince Charles, now the king, but presidents and prime ministers and a very high level participation, and there was a lot of pledges. I think we'll hear a little more of that later from our friend Toko. Then we have 2 days, 19 September, World Snakebite Day, and tomorrow is going to be World Rabies Day. Actually, it's a good time during the stag. So I think the idea was if we can have some snippets or quotes from the chair or members to put out on the social media to gain more traction on rabies. So just come back to the NTD Day. As you know, the NTD Day was being celebrated by partners on 30th of January. So so now this is officially as the WHO's NTD Day. And it was a very exceptional situation where the World Health Assembly was actually reviewing all the WHO days to its value and whether they really make sense, the funding behind, the value for money and all that. But there were some countries who did not want to wait for the NTD day decision. And the assembly agreed to have the WHO's NTD day on 30th of September, just that because the partners were also doing that. So that's been a very important aspect, and it was actually celebrated very well. And we'll see through lighting across the world, many cities, including our Jet d'eau in Geneva. Okay, so I'll just conclude now with some of the major challenges. I think throughout my presentation, it is probably very apparent that COVID-19 disruptions has been one of the major challenge. And again, this is a very small chart. You will see the bigger one on this is that countries have expressed that, what part of, 60% of those countries where disruptions happened, it was mainly on NTDs. So that is one thing. But also not only disruption in the services, it has also disrupted or changed the pattern of funding, moving funds from many of these disease programs to other area. There may be some positives in that, because if the health system gets strengthening, I think it also fall out on NTDs. But again, this is another area that again we are going to have presentations which discuss these issues a little more, so that you can have further a better understanding for your discussion. Many of the NTDs, we have a portfolio of 20. Not all the NTDs are well supported by stakeholders. So we try to do our best with the ones that are not really supported. So that's one challenge. And then again, many of the gaps that had been identified in the roadmap still continue to exist. I mean, it's a work in progress, I do understand, but those are also some of the major challenges, even including the three major shifts of the acceleration, mainstreaming, and the country ownership aspects. So I will conclude with those. I hope it gave you a good overview. And again, the idea was this should set the scene for your further discussion as you hear more detailed presentation from our colleagues from the regions, as well as the other presentations focused on the COVID disruptions. Thank you, Chair.
Thank you very much, Gautam. So it's impressive what's been achieved in spite of COVID. I think the work on diagnostics is really impressive, that all those target product profiles have been developed. As we discussed at the last DIAG meeting, we really think diagnostics are important, because in the new roadmap, measuring impact is key, and clearly as we approach elimination targets, diagnostics are crucial. I had one question, one point of clarification. So you mentioned that drug donations had been agreed, but you didn't mention Pfizer and azithromycin. Has a donation been agreed for that?
No, sorry if I wasn't clear on that slide. I think that slide only showed the ones where we have recently renewed the commitments through new MOUs. I did not list out the existing ones, which includes Pfizer and Merck for ivermectin and other things. So that continues. It was just to show the ones which have come up for renewal. That doesn't mean that the existing ones have stopped.
Okay, thank you. So we have half an hour for discussion after the coffee break. But I guess if there are any points of clarification or questions arising, we have a couple of minutes before the break. Anyone like to raise any issues? Yes, Wukong.
Yes, thank you very much for your presentation. I think it's excellent. It saved a lot of time to read a ton of the paper. So my question related to the donation, you mentioned about the medication donation. I think it's absolutely important but do you have information about the donation for the diagnostic? Because for me, you know, diagnostic and treatment should come together. And in some country, I believe that they have an underestimated burden of the disease because of lacking of the diagnostic. So in your vision, do you have a strategy to improvement of the drug donation and the diagnostic? Thank you.
Yes, a good question. So why we would like everything to be donated, that's not going to really happen. So I think what we are trying to do is two things before we get into the donation, is to first also get the right diagnostics, the diagnostics that we really need in the field, and with the quality that happens. So, and that's the work of the Diagnostic Technical Advisory Group. And I will let my colleague Daniel to add to this, so that we define the target product profile of the diagnostic that we need. The second step is to convert these into diagnostics and then make those diagnostics of quality accessible to the people, whether donation or not. So as of now, I at the best of my understanding, there is no donation of any diagnostic as such, like we have for medicines. But what we have is support from our partners to buy these diagnostics and make it available to the countries, and that we are continuing to do for many of the diagnostics across the board. Uh, but this is also an area that we are expecting countries also to step in and play their role of where their diagnostic needs are, and also part of the domestic financing. So it's a multi-pronged approach. Yes, first get the best diagnostic for the purpose of good quality, ensure that they should be affordable and available, and then we should have money, whether it comes from international sources or from within the country, to buy it. But if my colleagues can, I don't think we have any direct donation of any diagnostic from the producer. Daniel, you want to add something?
No, it's as you said, Gautam. There is no currently there is no donation for diagnostics, except some support for some of the entities from partners where WHO is coordinating the procurement of certain diagnostics. However, through DTAG, we have started a process, and we have also a subgroup under DTAG, which is a manufacturing and regulatory pathway that is trying to facilitate the development of diagnostics, not only the development, but also accelerating and facilitating the regulatory pathway, which is now is a hindrance for NTD diagnostics because of the low volume required, lack of market, etc. Even and also, of course, the status of the diagnostic manufacturers as not as big as the pharmaceuticals. So current discussion with many diagnostic manufacturers is to have a kind of tiered price or a negotiated price for NTD diagnostics. That is one. The second is to continue their production, because some are demotivated because of various reasons, like new rules on diagnostics, like the European IVDR, in vitro diagnostic regulation, which is requiring a lot of investment on the manufacturing part, and manufacturers are not willing to add on a product which is not profitable. So that is a discussion to encourage manufacturers to continue and also to inform them our priority diagnostic gaps. Thank you.
Li Ching, is that a raised hand?
Hi, congratulations to the progress that has been made. I thought the coordination with the other departments has been very nice. The formation of the Arbovirus Initiative and all that, putting different departments work together. But in previous meetings, we have mentioned about the coordination with WASH, the Water, Sanitation and Hygiene Group, and as we see NTD coming down, but Aedes-borne diseases coming up. So there was also discussion on infrastructure and urban planning. Just wondering what kind of approach has been taken. I think these are also have been incorporated into the roadmap. So wondering whether there will be some update on the approach that is taken to coordinate with infra and WASH to tackle NTDs. Thank you.
Yes, we do. I think we have a very good collaboration with our colleagues with WASH. One of the products, of course, was the earlier product of the WASH and NTD, joint product or publication that we had done. But yes, it is a follow-up to that. Saul, you want to add something on the WASH?
Yeah, so an update to the global strategy that was initially published for 2015 to 2020 has just come out as a companion document to the roadmap. And alongside that, there are two other things that are happening. One is a revision to the WASH and Health Working Together toolkit that was published, I think, for the first time in 2018. An update to that based on implementation and country experience will be published this year jointly by the NNN WASH Working Group and WHO. And the second thing that's happening is an online course that should be available in the first quarter of 2023, again on WASH and NTDs. An online course.
Okay, I see a few more hands up, but we have half an hour for questions and discussion after coffee. So before the coffee gets cold, shall we take coffee now? I think we have 20 minutes. Thank you. After coffee, Nasim, you are first.
Test.
That's good. And then
I think we should probably start because we have a heavy program before lunch. I just thought before we take more questions, I should explain to the new members of STAG the issue around the moratorium on new NTDs, which was agreed, I think, 2 or was it 3 years ago. The reason being that with 20 NTDs, it was felt that the staff in the NTD department who have to report annually on each of the 20, adding more would be too great a burden. And so the issue of NOMA was brought up and has been brought up several times. And the question is, it's clearly neglected. Does it fulfill the other criteria, which we could go into at some point?
Mm.
Is there a simple intervention that will get rid of it? That was really the issue. But I think the moratorium we've agreed will stay in place until next year.
Yes.
Yes, and yes. And then you, Nassim.
Make sure I get this right. I just wanted to catch this. If you're gonna talk about if you're moving on to another topic, and I think it's just more of a consideration for the STAG. This is obviously not going to be the first nor the last time that you're asked to consider additional diseases. And I think there's obviously the criteria that exists, but I guess I would also say, having been approached recently about NOMA, is some of the things that have been successful in the strategies that have worked for NTDs has been some of the, kind of clear interventions. So I think when we look at a disease like NOMA, it obviously is something that is neglected, but that's one factor, I guess, is just to take a serious look at the service delivery structure around that and what that means, not only for and in particular, I would say, what does that mean for an NTD program? NOMA is a very multifaceted strategy to deal with treatment and prevention. And so I just think as you have new diseases to consider, I think the complexity of the programming is just something to consider, as well as obviously the science. And so just ask people to think through that, because some of that requires a lot of very serious cross-sector coordination of services, and just what are the implications for national NTD programs as well.
Yes, thank you, Emily. Now, Nassim has had her hand up for some time, so over to you, Nassim.
Yes, I want to refer back to the question of diagnostics. So when you talk of diagnostics, I assume you're referring to the equipment and the kits and so on. But I'm wondering about complex diagnostics in animal and human rabies, which are not easily done everywhere. I was wondering if there is any provision from NTD for training people how to perform these diagnostics. I mean, that really is a big concern, because you can, I guess, buy the kits and so on, but it's how to use these and how to apply them. So that was my question. Thank you.
Thanks, Nassim. Who's going to answer that one?
I think if I understood your question correctly, you're referring to the capacities required to use diagnostics? Yeah. Okay. So in line with the development of the target product profiles, we are also doing various capacity building activities, especially as Gautam was presenting this morning. Different programs are preparing bench aid online courses that helps health workers to be able to do basic diagnosis at primary health care level. So one of the area, for example, most of our guidelines have have the diagnostic component, how to perform diagnostic at primary healthcare level or above level. And there are then these SOPs or standard operation procedure manuals, which also contains these activities. So now the discussion and the practice in WHO is to translate these guidelines into training materials so that health workers, wherever they are, they can access this WHO open platform, which is accessed, by millions. It has millions of registrants, over 70 million, people have registered, partly due to COVID and mainly due to COVID. So they have offered to NTD department a free platform. We are using that platform to develop and put some online training materials, including video clips demonstrating how to do it. That is one. The second is under the DTAG, we have established newly laboratory capacity and networking subgroup. We have some Pamela and also some people who are also coordinating and serving as a focal point for this. It has not met. It did? Yeah. So it will also meet soon, and then that will also help in furthering. Because the thing is, we cannot build capacity, especially we cannot build center of excellence for all diagnostics at all places. Some of the NTD diagnostics require secondary or tertiary level services. For those, what we are thinking is to build a networking center of excellence using the WHO collaborating centers where samples can be referred for further diagnostics, for example, whenever there is a need for species identification or antimicrobial resistance monitoring, etc.
Thank you. Akshay, your hand has been up for some time.
Thank you very much. At the outset, congratulations and excellent presentation by the director, taking us through the journey of last 3 years in the NTD. First, my thoughts is that I know Dr. Gautam is leaving us on 30th, but he has been sort of institution in the NTD even before coming to WHO. So my suggestion is that we should not lose an institution, and we should, means the STAG, I do not know whether whatever the WHO rules permit, we have some sort of human resource, life resource library, where the persons who are available, well experienced in the field, their expertise should not go waste. That is my first suggestion. My own. Second is for the donor issue, which we have been hearing, and in past entities, STAG also, this issue that what should be the guidelines. I feel it should be a good mix when donor support comes. Definitely, it should not kill the local industry. Local industry should also be encouraged. But having said so, when we are in a situation fix where some action has to be taken, some policy decision has to be taken, then whatever is available, that is my suggestion. Third suggestion is on the word One Health approach. Personally, I have been involved in India on this approach. We have been working and taking forward agenda, not only for zoonotic diseases, for AMR also. But my observation has been that we have been talking of One Health approach, but it has not taken ground. And means we have done some sort of introspection because it's a mix of different professionals, and we know, means sometime ego problem, sometime who takes the initiative, those sort of things. So we need to have more insight to understand this problem, that how means a lot of money, lot of investment is going, but whether it is worth spending that much of money without changing the strategic approach to One Health approach. Fourth thing regarding the new diseases, some of the members raised the issue. I would say definitely means whenever some problem is there, when it comes to the notice and which is really fitting in our definition, should be taken on board from the point of view of providing the technical guidance from the WHO side, from the NTD side, and then a discussion can be held when it comes down to adding to the number of diseases to be included under NTDs. So these are four suggestions from my side. Thank you very much.
Thank you. Would you like to respond to that, Gautam? Or?
I think I will take them as suggestions for discussion, but Bernadette, I don't know whether you got the question on the One Health, and if you want to respond to.
I didn't quite get it, to be honest.
Okay, so I think what Dr. Dhariwal, can you repeat your One Health question?
What I said for One Health approach, that One Health approach, no doubt, is very, very important that we have realized working as a public health practitioner, and particularly means COVID gave that impetus. But when we look back, it has not made ground. Still, many of our professionals, when I talk to them, they ask, what is this One Health approach? What are the different components? What we need to do? So those are the issues I am flagging. And I am flagging that if agreed by the STAC group, then a operational, I would say, a study can be commissioned to look at the different aspects, that if it is going well, means if hypothesis is that means somebody may feel offended who is looking after this One Health approach here at headquarter or in regional offices. No, we are doing very well. But let's reject that hypothesis also. That is what, as a professional, I feel. So my suggestion on board is that undertake a study to understand inside if there are cross-learning, good lessons learned, document it, and move forward with those inputs. Thank you.
Thank you. So the question is what we can do to make One Health happen. Is that right? How we can make sure that these recommendations are implemented. So would anyone like to comment on that? We have several people. Yes, Bernadette.
Good morning, everybody. I was actually present in the room, but in the overflow room earlier this morning. So it is a complex area, right? It's not the first time we've given it a name, One Health, where we're trying to really address the source of the problem rather than just controlling or managing the problem. So it's nothing new. We've got at the moment a better understanding from the larger community that One Health, what we call One Health, which could encompass also WASH, the environmental part of things, and not only the animal health side, is really important if we want a sustainable impact in controlling, eliminating, or eradicating our diseases. So it's not new, Dr. Arival, but it's complex. So it is really, we have an opportunity now because of the epidemic diseases where there is a great push to try to harmonize platforms like sharing of data. And then, of course, we have an opportunity to show the actual impact if you do address the source. Now, for NTDs, we really do have some diseases that can show quite quick impact if we took action. But we also need the political will for that. So I've just come back from India. If you're addressing rabies only by giving post-exposure prophylaxis, well, we'll never get rid of deaths from India. We need to start addressing the root cause, which is the dogs. Same with Taenia solium. If you want to get rid of epilepsy that is caused by Taenia solium, tapeworm, if we can get a handle on breaking that cycle of open defecation, pigs accessing human feces, bad sanitation. Again, that's beyond the animal health. It's really, so what I'm saying is we will need not only to use our technical tools, but we will need the support really of policy change. Policy change is slow. It's like a slow cook. But as we move that, we need to also build the informal networks to start pushing the agenda forward and push then the policy change and the governments to understand by seeing the evidence. I'm sorry if I'm taking too long. But one of our crucial problems, actually, we've been working on One Health. I've been in this department for 9 years now. Wow. And trying to address the source of the problem is really difficult to get support for. So, we haven't been sitting idle. We are pushing the agenda. It's now got a label. It's called One Health. Hope that answers.
Yes, thank you. It's clearly a very, very challenging issue. Yes.
Yeah, I think just to add to what Bernadette said, I think the One Health works when the other side, the veterinary side, is a livestock disease which is of value to the livestock people. But when it is like in bats or in dogs where there is no commercial value to these, and then there is a gap. Who takes care of them? So as you rightly said, the focus, we want that the dog vaccination should happen, but who will do it? Is it the municipality or is it the health system? I know there are some initiatives in Bangladesh because of someone interested would go out, but systemically, I think that's where it is lacking. And I know. Political will needs to be there, but I believe that's the point Dr. Dhariwal is trying to make. That while we all agree to the One Health approach, I think things to make changes at the ground level is still we're struggling.
Margaret, thank you. Next.
Thank you very much to Gautam and the team for that comprehensive report. Like David said, 103 pages. I went through that document, but it was refreshing to read and see the updates on everything that was going on. I think that there was something missing, maybe in my opinion, because of my area of interest with genital schisto. We talked about, the roadmap highlights partnership a lot. And one of the big areas of partnership that the Schisto group has had is with the HIV group. So there have been a lot of publications, there have been huge international meetings organized by the HIV group where female genital schisto has featured prominently. So that's a real good example of cross-sectoral partnerships. And I think if we highlight that a bit in the report to show that NTD is working across sectors with a group that is interested in women's health will be important. Then I looked at the tables with the data and my heart began to sink because I saw all these zeros and gaps. And I'm like, 2030 is not far away. We need data to be able to show evidence we are making progress. And if we have so many gaps and so many zeros for those tables, then I was asking myself, where are we getting to? What can we do to get countries to report? Are they getting overwhelmed? I clicked on the link for the DHIS2. It takes you to a WHO page. And then I'm asking myself, do they report separately into that page from what they are reporting at country level? What is it that is making it difficult for countries to submit data? I quickly sent a text message home and said, Ghana, your place is blank, but I know you collect data. What is going on? Why is the data not coming up for us to use? So we need to look at what is it that is not making countries report? Because if they don't report, then we cannot really estimate where we are in terms of meeting the goals for the roadmap. Then for the online courses, I heard you say 50,000 people had enrolled, but I didn't hear about completion. These days with these online stuff, everybody registers, and then you have 500 people registered and only 2 participated. So it will be important, because if we think that people need to take these courses to understand the different products, then we have to be sure that people are actually not just registering, but taking the courses and completing them. And then we are sure that people really are getting what is going on. In terms of the drug donations and what to do with leftover drugs, some work that we've been doing in Cote d'Ivoire, Kenya, Ghana, Uganda with some of my other colleagues, it is sometimes heartbreaking to see what happens. Some of the community drug distributors are saying, well, when we come for the training to distribute, we are giving money for transport. After the distribution, nobody is interested in us. They said, bring the drugs to the health facility. How do we come to the health facility if we are at the remotest places? So the drugs are stuck with them. If they don't find space, they just throw them away. It's not surprising that during COVID, people were saying, okay, we have ivermectin, let's use it. You know, so there are issues about expired drugs, what to do with it. And I was happy with the new Schisto guidelines. After years of yelling, now the leftover drugs for praziquantel are supposed to be left in the health facility so that anybody presenting with blood in urine can get some of those. So I think this is one example for schistosomiasis, but maybe we can look at it in terms of other drugs for mass drug administration and come up with a clear statement on what to do, because people may not be getting the drugs in their homes, but somebody may fall sick, arrive there, and then some health worker may see that you have LF or you have something, and they have access to ivermectin, which they can give. These are health system issues that I want to bring up. Thank you very much.
Thanks, Margaret. Yes, very, very good points. Any response to that, Gautam?
No, I think as always, Margaret, you bring in very important points, and I'll just give the floor to, I see Pamela there, to talk about the genital schistosomiasis, because things have been working. I mean, I didn't cover everything on, in the presentation, but I can assure you there is a lot of work being done with colleagues and partners on the genital schistosomiasis front. One of the things that you bring up on the zeros that you see, and we purposely left those zeros. We wanted you to see those zeros and the gaps that we have, and this is where, one of the challenges I said, some of the diseases get a lot of traction, and there is a lot of interest both within the country with the partners and others, and there is this reporting, but many of the diseases don't. We don't even know the burden. The countries don't know the burden where these diseases exist to have a response. So this is an area that is part of what the working group on MNE is, has been advising us. And again, what we again, within the context of the roadmap, what we are trying to do is ensure that before data comes to WHO, it is in the national system, and the country or the district is actually using it to making decisions. I think we don't want that, we are just trying to ask, give us the data. No, but the data has to be generated for their own use, the first thing. Unless countries see the benefit and value of collecting the data for their own use, I mean, just sending somewhere is not going to be very easy. The second thing is, what is the data definitions and all that? That's what I mentioned about the indicator compendium. We are trying, many of the countries now use DHIS2, but many don't. And we do not want to prescribe a system the country should use. Any system the country is using and comfortable using should be able to use the indicators that they need to collect for the making of the decision. That's part of the health facility data toolkit that we are working on with, again, our colleagues at the DDI. Just to mention, WHO is also now forward thinking in terms of a world data hub. And they are going to have country portals where there is a standard way of exchange of information from the countries, what information needs to be collected. We have also heard from the countryside that WHO is just collecting a lot of information, and that is also what we want to avoid. So yeah, it's a complex thing. We're aware of it. We're doing. I'll just give the floor to Pamela for a short comment on that.
Thank you. Good morning, everyone. My name is Pamela Mbabazi. I'm with the department based here at headquarters in the unit that works on strategic information and responsible for monitoring and evaluation, among other things. I'll present my comments, address the inputs that Professor Japong shared, with the background that the STAG did call for the establishment of a working group on gender equity and rights. So the work that we've been doing with on female genital schistosomiasis fits very nicely into some of the scope of work that that technical working group is meant to address. The work with the female genital schistosomiasis has really taken traction over, now it's coming to nearly 20 years. We last had our last WHO technical consultation meeting in 2009. We are anticipating that we'll have a follow-up consultation meeting either later this year or early next year. So it's more than 10 years since we had that. But in the meantime, a lot has happened. And in there, we've had a lot of interactions and traction that we've gained working with our colleagues in UNAIDS and the HIV department. So there are a number of publications that actually have come out and taken advocacy documents. That being said, though, this type of work on FGS especially has also led some countries like the National FGS Society. There's also call for more attention to having an interagency committee or group working on such an initiative on FGS, HIV, and bringing more UN agencies like UNFPA along with WHO and UN. So it's something, an area of work which is growing and calling for more leadership and stronger coordination. The FGS and HIV gives just one example of what we need to be doing in this gender equity and rights space for NTDs. While the technical working group on gender equity and rights has not been formally formulated and working, there is a lot of work that has actually been happening in the department on this specific topic. I can give examples from leprosy. There are also work that's been coming in from the Chagas group and the Trachoma group. There was also a scoping study that was done with the Polygia group and TDR with a group of students from Cambridge University, and it really did highlight some of the key things we need to be doing with regard to gender equity and rights. This is a report that covers a period of more than 20 years since the last one was put out by the same TDR in the mid-1990s. And so I'll summarize by saying that in the next tag, we should present you a report of what's actually happening with regard to gender equity and rights in more details for NTDs, but also call that this is an area of work for which we need support going forward. And not just mention something that we are doing, but we do need to put resources towards it because it does require some resources. And there's a lot of interesting things that are going on in this space for which we as a department are also required to demonstrate leadership as we work and need to work through interagency and intersectoral mechanisms. Thank you.
Yes, thanks. Now we have some online people with their hands up. Dr. Dhingra, I think you've had your hand up for a while. Are you there?
Yeah, thank you. Thank you very much. It's very heartening to know that during COVID times, from the report which Dr. Gautam Vishwas has presented, work has been going on. That means the thinkful job has been going on. That's very heartening to know. My things are more like inquisitiveness rather than a question. I think I did see in various reports that were sent online, there has been disruption of services due to COVID, and a definite percentage which has been carried out by services have been given. And I think Dr. Vishwas' presentation also showed that there has been disruption of services. In India especially, also we are talking about visceral leishmaniasis elimination, the active surveillance, detection of cases and giving treatment, definitely there has been problem. There has been problem in preventive chemotherapy. And as Dr. Vishwas also said, there has been decline or less use of drugs as well as less funding. The issue is what impact it will have in the coming days. For example, if you miss 1 or 2 years of detection and treatment, how much would it affect the disease in the coming years? It may be very difficult to assess, or it can be assessed, but definitely it will be important for the policymakers, for the various partners to know that quantum is not going to decrease, it may increase, and programs may need more funding, more robust type of preventive chemotherapy, case detection, and also looking into all treatment aspects. This brings us back to the issue which was being raised about the donation. And I think it can become a problem if the firms who are giving donation are not aware that there may be a jump or there might be increase in the requirement of drugs and diagnostics. That's one aspect that we need to look into. I'm not sure, can we make some assessment how much may we get an increase in the disease, or maybe, or disease, or whatever way we can do it. That's it. Thank you very much. Thank you.
Thank you. And we also have Susanna Pasnieri with her hand up, I think. Susanna?
Thanks. I think it's a maybe mix of comments and questions, and maybe just the fact that I'm new in the group, so maybe some requests for clarifications. One thing is going back to the donation slide, and apologies if I didn't catch all of it, but I guess one question I had, or proposal for discussion, is around additional ivermectin donations for the implementation of scabies control programs. Now that there are guidelines, I'm sure there's lots of movement in the background, or trying to secure funds. I mean, as we are all aware, probably there's kind of a handful of countries securing ivermectin donations for scabies, ivermectin MDA for scabies control, due to other donors acting or active in small Pacific Island countries. But I wonder if there's a broader sort of movement trying to find additional donations. And then a similar question for azithromycin for yaws elimination or eradication. And, I believe there's been some, I guess, problems sometimes with bringing on board additional or new pharmaceutical companies that have committed to support, besides Pfizer, that have committed azithromycin donations for yaws, but sometimes there's some glitches with the supply chain, and making sure that new pharmaceutical companies are supported in terms of their procurement and logistics, even, especially if they are less experienced with the process. I'm aware that I think there's like WHO supporting mechanisms for the already, group of pharmaceutical companies who have committed donations. So I was just wondering, if there needs to be additional work for adding new pharmaceuticals to that group, so that they can, have some support when they're trying to support countries. My other comment was around diagnostics, not so much in terms of new diagnostics, but with existing diagnostic tools, again, for yaws. I believe at points there are some issues with the supply of DPP, so that countries can continue to have DPP to support their yaws elimination strategy. And I wonder if this is being discussed. And in terms of the new, now going back to the other thing, the NOMA and the addition of additional NTDs, again, I'm not aware where, or I assume, or I imagine that there could be a similar sort of interest from the LOASIs, and I believe there was also a recent paper like the one on NOMA, but there was a more recent one of trying to gather support for adding LOA to the NTD list. That's it. Thank you very much.
Thank you, Susanna. Now we have 4 hands up in the room, I think, or 5 now. But I'm not sure. We have more time for discussion after the presentations. And should we save the questions for later, because we have our regional...
I would suggest that some of the questions may also be addressed in the subsequent sessions. So maybe if you agree, then maybe withhold, otherwise we'll not move to the
So we should hold the questions for later.
Yeah.
Yes, because we have the progress from the regions coming up in 2 minutes, and I guess there may be people.
In fact, we are kind of accumulating the questions, so maybe
Yes.
at some point we can give a response.
Of course, yes. Perhaps we have time for one? No, I think probably it's time to move on.
You are the chair.
It is 11:20 or 11:19. So we'll keep those questions for the later session at 12:30. And we would like to hear about progress from the regions, please.
Start with that.
Yes, we start with Afro, go in alphabetical order. So Regional Office for Africa first. Seydou, you have the floor.
Mr. Chair, thank you, Albis, and good morning, colleagues. My name is Andrew Seydou Koko, member of the NTD team in Afro, and have specific responsibility for guinea worm eradication and snakebite envenoming. Next slide, please. As most of you are already aware, we have 19 of the NTDs in the Afro portfolio, 5 of which are amenable to preventive chemotherapy and 14 are case management NTDs. Even out of the 14, less than half of them are currently well-funded or funded, sort of, and implementing. So we've targeted 2 diseases for eradication, guinea worm and yaws. And as of today, 6 countries, 41 countries have been certified and 6 remain to be certified. As mentioned by Gautam earlier, DRC was visited a few months ago to verify the country's claim for having met the criteria for certification. In all this, in the remaining 5 countries, animal infection remains a major challenge, and we have to work to address that, because if we're talking, the target is eradication. It means that after the certification of DRC, at least in Afro, it means that the next time that we can certify a country is most likely to be the next 4 years, because it takes a minimum of 4 years. This is not to discourage anybody, but to tell us that we still have a long way to go. The process is slow, and this is the time for us to work harder to mobilize resources that we need to finish the course by 2030. Yours, 9 countries remain to be endemic, and I am happy to indicate that, to announce that to support more efforts for countries to on the road to eradication. 3 countries, Cameroon, Central African Republic, are now implementing the total community treatment for yours using azithromycin. For heart elimination, the continental threshold of 300 cases, 2,000 cases has been achieved and sustained for quite some time now. And over the past, next slide. Oh, sorry for that. And over the past 3 years, 6 countries have been validated for having eliminated heart as a public health problem. An additional 6 are in various stages of preparing their dossier for validation. Visual leishmaniasis remains a problem in 8 countries, 5 of them high, mostly in East Africa, and some of 3 low-bearing countries in West and Central Africa. Of the NTDs targeted for controlling the region now, Borrelia also and cutaneous leishmaniasis have been on for some time with some funding, although we're having challenges with funding for leishmaniasis now. Rabies are again issues of challenge, because we don't have funding to implement activities, and then to make things worse, they've been newly added NTDs, mycetoma and other deep mycosis, scabies and ectoparasites, and snakebite envenoming. Of course, we've just started to implement the snakebite envenoming program, but we still have challenges in funding. We discussed this morning about the probable addition of adding NOMA to the NTD portfolio, pending the decision of
STAG, we are already collaborating with our colleagues in the non-communicable cluster unit, and we are gathering information on mycetoma and NOMA at the same time using the extracted questionnaire. In the area of PC, the 5 diseases, 38 of the 47 countries. Next slide. Yes. 38 of the 47 countries have reached 100% geographic coverage as of the close of 2020. And the number of people requiring preventive, this one, number of people requiring treatment has decreased from over 590 million to just about 580 million as of the end of 2020. Now, so far, as of this year, the data for 2021 coverage is still being analyzed, but there are indications that the coverage may be lower than the previous year. And this basically is as a result of the late lockdown measures from COVID, and also recently by the lack of funding from or withdrawal of funding for NTD activities. Some surveys are ongoing to establish the impact of previous treatments. Again, I'm happy to announce, as already mentioned by Gautam, that Togo is the first country to have eliminated 4 entities. This is including the fact that it has already eradicated dracunculiasis. And Togo's achievements was duly recognized during the last meeting of the RC72 in August of this year. Our key challenges, the major challenge is inadequate government funding, demonstrated by relatively insufficient funding and the low level of integration of NTD programs. Everybody is still standing on his own. And many, as I already mentioned, interventions against many of the newly added NTDs are yet to take off because we do not have funding. We have requests from countries, can we help this, can we help this, but what do you have for us? But we can't provide them with anything. In general, what it means is that most of our programs are donor funded. There's no mobilized funds from the government to support these issues. Most NTD activities are community-based, and anytime there's insecurity, we are severely affected. And we are all aware of the hotspots in the region, in Mali, in West Africa, in Central Africa, and East Africa. All of this go on to affect program implementation at the field level. We also have some challenges with staffing, especially at the country offices, where we don't have dedicated NTD staff. Well, in the spirit of integration and collaboration and things here and there, NTD is always represented by, at the country level, by other units like malaria and vector-borne diseases. Nevertheless, having put full-time people at the country level to focus on NTDs remains a challenge. So, against all this, I would like to mention to you that there's some restructuring, or there has been some restructuring in the UCN cluster, and you can see that malaria is the NTD, malaria and vector-borne, the one I circled red, are now formed under one program called tropical and vector-borne diseases. So NTD, malaria, and vector-borne diseases fall under one subunit called TVD. And we continue to link up with our colleagues, SPN, who are basically focused on the 5 NTDs. And the implication is that for going forward, we have not come up with regional NTD-specific framework. Everything was integrated into one framework called the Tropical and Vector-Borne Disease Framework, which harmonizes individual frameworks from the 3 programs that make up the TVD framework. And this was ratified, or it was adopted by member states at the meeting that was held in Togo this year. So it becomes the reference document for all NTD activities in Afro. And one of the first steps that we're doing is we're realigning the national plans with the global NTD roadmap and TVD framework. We have produced regional guidelines that we've shared with the countries, and we've recruited, still recruiting and deploying NTD consultants to support the countries to finalize their multi-year frameworks. And another area of interest, which we're taking very seriously, is continue to facilitate ongoing opportunities for collaboration, integration, where possible, or co-implementation. And there are a number of people in this room which I believe are already aware of some of these initiatives. Bridges is supporting us implement a pilot project in Ghana to see how we can use the health system and the already existing structures to build on to build on our individual areas. We have an NTD investment case, again in collaboration with RTI, which is being piloted in Ghana, and then NTD mental health toolkit. We're working with our colleagues in the mental health in Afro and HQ to implement in Nigeria. WASH, we've been talking about WASH a lot in this meeting. So we're piloting a project or a phase in Ethiopia, and all these lessons the lessons coming out of this will be utilized or will be used in scaling up if positive. One Health. Recently, we've been talking with the GIZ, who initiated a discussion with ESPN on the use of One Health, on the importance of One Health. I wouldn't want to talk too much about that. We've already spoken a lot, but during the initial discussions that we from the case management team were invited, it generally occurred to us that in our region, we don't seem to have colleagues from the veterinary side that are supporting us in this area. And so these are areas of discussion that we are trying to take up with the senior management to see how we can work across all sectors, because the One Health is not just NTD, but it affects all the other programs under TVD and possibly in the emergency response. And recently, I also just mentioned the collaboration we are already having with NOMA. I believe this is the end of the presentation. There are additional slides which are hidden here and they are available for reference. Thank you.
Thank you very much. Very nice, comprehensive presentation. Who's next?
It's Amro. So Santiago, you have the floor. We will share the screen from our end.
Thank you very much, Albis. Thank you for presenting the slides from your end. So you can have the first one, please.
Yep.
So I'm just going to give a brief overview of the impact of COVID-19 in our region, and next, please, and to a certain extent, how are we recovering from the COVID-19 impact? So as in almost every region or every region, the pandemic had a negative impact on the allocation of financial and human resources to NTD programs, which were mostly reallocated to the response to the pandemic. And investment in NTDs was affected, obviously, and regaining the pre-pandemic levels or close to the pre-pandemic levels will require major efforts by all levels of the organization and partners. In 2020, almost no NDA were done in the region. Only a few communities were treated for onco, as I remember, in Venezuela and Brazil, but with a low geographical coverage. But MDA for STH, LF, and others were interrupted. But by 2022, most of the countries had restarted the MDA campaigns, and some of the countries resumed the population-based surveys. Next. Also the public health surveillance actions, as well as interprogrammatic and intersectoral interventions, were affected by the pandemic. One clear example of the impact of the public health surveillance actions was the leprosy, the detection of new leprosy cases, which in the region as well as globally fell by approximately 35% in 2020 as compared to 2019, and recovered slightly, not as much as we expected in 2021. There was a slight recovery, but we should have expected some more. Also, there was some reaction of the population due to the fears of COVID pandemic mainly, an interruption of activities focused to eliminate some diseases. And finally, as you know, also we have had some supply chain constraints. We had some issues regarding the prompt shipment and delivery of MDT to Brazil, for example, in 2020, which caused some difficulties. Also, delivery of some other drugs, and currently we're experiencing some delays in delivery, for example, of FTS tests for some surveys that we're planning in Guyana and Brazil. Next. So some of the things that can be highlighted regarding the recovery is that most of the countries have restarted MDA and have resumed some of the population-based survey. Lymphatic filariasis elimination as a public health problem is advancing in Guyana. I will present this in a little more detail in the next presentation on field voices from the field. Documentation of the schistosomiasis transmission, of interruption of schisto transmission in the Caribbean is moving forward. Also, there have been advances in tenasis and cysticercosis, identification of risk areas mainly. Next. And also in Chagas disease, the results of antibacterial control achieved on household treatments prior to the pandemic have been maintained, fortunately, but there's remains some challenges still remains, including the care of patients and the congenital Chagas disease control. Next, please. Regarding arboviral diseases, there's a lot of progress, also advances integrated surveillance of arboviruses, improvements in diagnosis and clinical management, and strengthening of the network of arboviral diseases diagnostic laboratories were expanded. Also, dengue genomic surveillance and entomological surveillance. Next. And in public health entomology, also, well, some progress have been made. The need to strengthen, there's a need to strengthen technical and operational capacities in the different components of the IVM. Also guarantee political support and financial and human resources, and the need to continue to strengthen the technical capacity of the people, the professionals and the healthcare workers, carrying out the entomological surveillance and vector control interventions, and consider the impact that COVID-19 has had on the plan and activities of the vector-borne diseases prevention and control. Next. In some of the proposed actions include regional advocacy efforts at the highest level with Ministry of Health to recover the performance of NTD control programs, not only the performance, but also the financial and human resources that should be allocated, and of course the performance, intensify internal work efforts at WHO and the regional office to promote interprogrammatic work and effective implementation of One Health approaches. Next. And finally, accelerate the development. We think this is crucial. This has been mentioned before, but the development of laboratory tests and facilitate rapid access to countries to support elimination processes and integrated surveillance tools, including serosurveillance, multiplex, for example, monitoring, integrated monitoring of neglected tropical skin diseases, to expand and accelerate their use in countries. I think this is the last one, Alves, but I wouldn't like to finish this presentation without thanking very much Dr. Biswas Gautam. It has been a pleasure to work with you over all these years. We really appreciate your friendship and all the support you've given to to us in our region, and we will surely miss you, but we wish you all the best. Thank you very much.
Thank you very much. Who is next?
So Regional Office for the Eastern Mediterranean, Dr. Supriya, you have the floor.
Sorry, I didn't hear that.
Thank you. Thank you. Can I have the slides? So I am Supriya Varusavitana. I am the Regional Advisor NTDs from the WHO Eastern Mediterranean Regional Office. Next slide, please. So I will be presenting the regional progress and the overview of the NTD overview of the region and the progress what we have been made during the last 1 year. Just to give a small introduction of the region, especially for the new STAC members, this region comprises of 21 member states and occupied Palestinian territory, with nearly about more than 745 million people. More than 2/3 of the countries in this region are affected by natural or man-made emergencies. So you can understand the burden, more than the NTD burden, the obstacles we face in implementing the NTD interventions to control and elimination. And this region reports nearly every year, this region reports nearly more than 75% of the global burden of cutaneous leishmaniasis. Can Farah have another click? Okay, so all the member states are affected by at least one NTD, and some of the countries have reported re-emergence of NTDs due to the conflict and humanitarian emergencies. And these countries have almost not reported the NTD, these specific NTDs before the country faced these humanitarian emergencies. And debilitating health systems in majority of the countries is one of the key obstacles to combat NTDs. Next slide, please. Before the progress on the implementation of preventive chemotherapy, I will also give a brief on the 2 NTDs which are targeted for eradication. So Sudan is the only country which has not been certified for eradicating dracunculiasis, and we are working on that. We hope that by next year we will be able to certify Sudan for eradicating dracunculiasis. Related to yours, Somalia reported a case. I mean, Somalia was identified as formerly endemic. So we have to conduct the assessment for Somalia to certify eradication of yours. Next, please. So this is the brief overview of the, another click, Farah. Yeah. So this is a brief overview of the preventive chemotherapy implementation in the region. Among the 22 countries, 9 countries require preventive chemotherapy to control and eliminate the 5 NTDs. Sudan, for the lymphatic filariasis, Sudan is the only country which requires mass drug administration to eliminate the lymphatic filariasis. Egypt and Yemen have been validated for eliminating lymphatic filariasis as a public health problem. Schistosomiasis, Egypt, Sudan, Yemen, and Somalia are endemic for the disease. Somalia, they also needs mass drug administration to eliminate the disease. During the mass drug, this is the latest coverage which was reported in the latest MDA the countries conducted during this year or the last year, mostly last year. So Somalia had a less coverage, but Egypt, Sudan, and Yemen had a good coverage during the implementation of the mass drug administration. Soil-transmitted helminthiasis, Afghanistan, Djibouti, Iraq, Pakistan, Sudan, Yemen, Somalia, and Syria still requires mass drug administration to eliminate the soil-transmitted helminthiasis. Somalia and Syria shows a good coverage, but the other countries had a not very successful coverage. Trachoma, Afghanistan, Egypt, Sudan, Somalia, and Yemen still requires mass drug administration as well as to implement the other components of SAFE strategy to eliminate trachoma. Iraq has submitted the dossier to dossier review group to validate the country for eliminating trachoma as a public health problem. Tunisia is preparing the dossier and hopefully it will be submitted by next year. Libya and Pakistan also have to initiate the dossier development. So Iraq, Tunisia, Libya and Pakistan, they have reached the elimination targets for trachoma. Iran, Morocco, Oman and Saudi Arabia have been validated for eliminating trachoma as a public health problem. Only Sudan and Yemen have to carry out the interventions to eliminate onchocerciasis, and both the countries are performing satisfactorily while implementing the mass drug administration to eliminate onchocerciasis. Next, please. So this is the let's see the status of the NTDs which for under the case management. Yes, please. The next. Yeah. So as mentioned already. And Farah, give more clicks. Thank you. So, as already mentioned, this region has the largest the global burden of cutaneous leishmaniasis, and more in the Afghanistan, Iraq, Pakistan, and Syria reports nearly 87% of the regional burden. So, if we can control the cutaneous leishmaniasis in Afghanistan, Iraq, Pakistan, and Syria, we will achieve the reduction of the cutaneous leishmaniasis in our region. Next, please. We also have a significant burden of visceral leishmaniasis. Most of the cases are reported from Sudan, Somalia, Iraq, and since 2019, Yemen has started reporting increased number of cases. So more than 50% of the cases in the region is reported from Sudan. Next, please. Thank you. So even though we see a declining trend in the of the leprosy cases reported since 2018, still we have a significant number of cases reported by the countries. But most Gulf countries in our region, they only report imported cases. They don't have autochthonous cases either, or they don't report autochthonous cases. The countries which are reporting autochthonous cases are Afghanistan, Egypt, Pakistan, Somalia, Sudan, and Yemen. So these are the 6 countries which reports large number of leprosy cases in the region. Next, please. So the child leprosy cases has had a decline since 2017, but again since 2019 we see an increase of the child leprosy cases. Grade 2 disability cases has shown a declining trend over the years. Next, please. So regional highlights. This is the progress on the SDG indicator 3.3.5. That is the number of people requiring interventions against neglected tropical diseases. For another click, please. Yeah. So when since 2010, there is a 53% decrease in the number of people requiring interventions against neglected tropical diseases, which is a good achievement for the region. Next slide, please. So 6 countries in the region have eliminated at least one NTD, starting from Oman in 2012, eliminated trachoma as a public health problem, followed by Morocco in 2016, and then 2018, Iran validated for eliminating trachoma, and the latest addition was Saudi Arabia in 2022. In other than that, Egypt and Yemen have been validated for eliminating lymphatic filariasis as a public health problem. Next, please. Next slide, please. So this is the eliminating the Saudi Arabia getting the WHO validation for eliminating trachoma as a public health problem. Next, please. Our region has developed the regional plan for the next 5 years to accelerate the implementation of the global roadmap for the NTDs. And this regional plan provides critical programmatic actions to accelerate the implementation of NTD roadmap with country-specific targets and milestones. And these critical programmatic actions we provided in under the 4 categories. So the actions for planning, actions under planning, governance, and program implementation, actions under the operational and normative guidance, monitoring and evaluation, and access and logistics. Next, please. Also during this year, just like the HQ and NTD HQ established STAG, we also revised our regional program review group, and and earlier it was only focused on the preventive chemotherapy NTDs, but we expanded the TOR, and now we established a new regional program review group to cover all the NTDs. And this was all the members were selected through the open call, and we have 9 members representing region as well as the extra region. Next, please. We also commemorated the World NTD Day this year at regional level as well as the country level. And this is one of the posters we developed to commemorate the World NTD Day this year. Thank you.
Thank you very much. Good work under difficult circumstances. Who's next?
So we have Regional Office for Southeast Asia. Dr. Ayaya Juma is going to share the slides from her end. Aya, you have the floor.
Thank you. Can you see full screen?
Yeah, we can see the screen. If you can turn your camera on, we may also be able to see you.
I did.
Okay, we don't see you. Anyway, go ahead.
Anyway, so my name is Ayaya Juma. I'm the regional advisor on NTD in WHO CRO. Yeah.
Okay, we can see you now. Go ahead.
Okay. So thank you for this opportunity. So I will start with a very quick summary. So in our region, we have 11 member states and 12 NTDs or NTD groups are endemic, at least one in every member state. But I will not give all the details. So I will go disease by disease. So just to let you know, in the CRO, the eliminating NTD in the verge of elimination is one of the regional flagship priorities selected by our regional director. So we have a very good support from the office, but also from the country offices for this work. So starting with lymphatic filariasis, so out of 9 endemic countries in the region, 3 has already been validated for elimination as a public health problem. And the next country, Bangladesh, is also finished the task 3 in nationwide and then preparing for dossier for validation. And the Timor-Leste also stopped MDA in the end of last year, and then now under post-MDA surveillance. And actually, the final task due next year. Then now we have 4 countries remaining, and of which 48% of all implementation units have also stopped MDA, and the rest of the IU's implementation units are rolling out or preparing for the rollout of the IDA, the triple drug therapy. And this June, we had a full physical regional program review group meeting in Delhi, and we discussed several challenges that included persistent transmission of LF and repeated LF survey PERA in the area with a long history of MDA in all remaining countries, and even after the IDA introduction. So we are still discussing the potential factors and how to address, such as MDA compliance, and possible poor quality of RDT itself or the testing quality. Also, we have a concern on the quality of drug, especially in some of the countries in our region are procuring the domestically the MDA drugs. And also we have a cross-border issue, for example, in many of the positive cases or the implementation units that continue to fail transmission assessment survey or pre-task is in Nepal, is across the border with India. So actually at this moment, we are having the discussion. So malaria program is planning the cross-border meeting with between India and Nepal in January next year, and we are negotiating to have an NTD also included together in this meeting to further discuss on the cross-border collaboration. And we also have a challenge with the revised the upcoming MNE protocol that will require the rebuilding or re-strengthening of the program capacity for LF impact assessment, particularly with the introduction of the reintroduction of the blood smear in addition to RDT use. So that's another challenge to tackle with. And we also have an India-specific challenge in our region with the insufficient donation of quality-assured ivermectin and FTS for IDA expansion in India, especially before the India's implementation unit was the district level, but then because district in India is still very big, so now they are changing the implementation units to the block level, so which increase significantly the need of the filarial test strip, and so that's another challenge that facing our region. Then also the country that has already been validated, we really need to support strengthening the post-validation surveillance. So that's the challenge we are prioritizing in the coming years. The next disease targeted for elimination is visceral leishmaniasis or CARAZA. So again, our region has a very good progress. So the number of reported VL cases in the region has declined in the last 15 years by 96% by end of last year. And even by the end of last year, so 99% of the all endemic implementation units in the region has achieved a target for elimination as a public health problem, which is 1 per 10,000 population at the sub-district level. And only 10 implementation units remain above the elimination threats. So we are gearing towards accelerating this VL elimination in the region. And so early this year, we organized a regional technical advisory group meeting, and we have discussed, and we are about to launch a new regional strategy for accelerating and sustaining VL elimination. And with the major focus on, maybe let me tell that, because the current challenges that we have been facing for CARAZA elimination, one is despite the number of cases really going down, but then we continue to have a reported cases of PKDL, which is a post-CARAZA dermal leishmaniasis, and relapse cases, and also cutaneous leishmaniasis cases continuing in all countries. And also we have a reported spreading of endemicity in the district, which is traditionally was not endemic. Also, we have a lack of, globally, we have a lack of appropriate tools for diagnosis and management of PKDL, relapse cases, and HIV-VL co-infection. And especially now that the cases are going down, then sustaining the health system capacity to deliver the post-elimination strategies such as routine surveillance, active case detection, and also the vector control intervention is really becoming more challenging. So we are looking at the more integrated approach for these activities to sustain the intervention beyond the validation. And one of the issues, again, the cross-border coordination, especially between India and the neighboring countries. So this is, again, what we reached to discuss in the January 2023 meeting, starting with the meeting between the India and Nepal. Then for leprosy, so in our region, again, the region has the highest burden of the leprosy in the world. And in the last 5 years, Bhutan, DPRK, Korea, and Maldives has reported less than 25 new leprosy cases annually. However, overall, the number of new cases remain around 150,000 in the last 15 years, with India accounting for 80% of the regional burden. And sorry, the graph is very small, but then the left side is the number of cases reported, and then the right side is case detection rate. And so you can see that both the number of cases reported and also new case detection rate remain stagnant in the last 15 years. So we really need a new strategy and not continuing business as usual. And one of the priority for us to push or accelerate is to roll out the single dose rifampicin post-exposure prophylaxis, which is basically the targeted MDA, and together with strengthening of AMR surveillance. And we are planning to revitalize the regional collaboration cross-learning across the countries from next year onwards. And for the YOS, we have 3 endemic countries, and India as the first country verified for elimination in 2016. And then now Timor-Leste also found 0 cases in nationwide survey integrated with LFTAS the last year. So we have a plan to conduct another nationwide sero survey in children, asymptomatic children, and big start dossier development in 2023. And for trachoma, out of 3 endemic countries, 2 has already been validated for elimination as a public health problem. And India is the remaining country, but India is also undertaking the pre-validation survey nationwide, and this to be completed hopefully by end of next year. And schistosomiasis is only endemic in 1 country, Indonesia, and only 20 villages in central Sulawesi. And they have already a very low prevalence after years of effective MDA, but there is a need to strengthen the surveillance towards the verification of the interaction transmission. So we are next year planning to organize a program evaluation of the current situation of the cysto. And also we are facilitating the bilateral cooperation with Philippines together because both countries have a cysto japonicum endemic. And we have a very good the experience in the Philippines to strengthen the surveillance activity. So we are facilitating this bilateral cooperation to strengthen the cysto surveillance from next year onwards. Then for STH, 8 countries requiring school deworming, and 5 countries have been sustaining over 80% deworming coverage for school-age children. But India also sustained 100% coverage, 100% in 2015 to 2017, but the coverage has reduced since then. And Nepal and Indonesia is enhancing coverage to and beyond 75%. And now the challenge is that despite the many countries now sustaining a good coverage, we have overall the limited resources and capacity to conduct a regular impact assessment. And there is a need to assess and revisit the treatment strategy in area with long years of deworming. So this is another area that we are trying to push every countries to move forward. Then this is not the disease, again, sorry, including STH. This is not the disease targeted for elimination, but more for the control. But snake bite envenoming, we are also strengthening the work on this. So our region bears the highest incidence and also highest number of snakebite deaths in the world, accounting for 70% of the estimated global burden. But only 30% of the country have national program, and only 2 has national strategy related to snakebite envenoming. And we have a very gross underreporting of the burden data. So this March, we organized a regional consultation, and we are soon launching the regional action plan for the control and prevention of snakebite envenoming, and to support member states establish the snakebite program and strengthening the intervention in every aspect. And in terms of rabies, also again, CRO bears the highest incidence and deaths due to rabies in the world, and 9 out of 11 member states are endemic. And so we are currently conducting the rabies program review with all countries and to put together the summary of the current situation. And we also are establishing the regional technical advisory group on dog-mediated human rabies this year to review the situation more regularly and then determine the priority and evaluate or monitor the progress forward. And we are planning to have the first RTAG meeting in the beginning of next year. And we are also closely working with FAO and WOA, which is the former OIE, at the regional level. And currently we are discussing to convene the regional tripartite ASEAN or SAC rabies meeting in 2023. We supported a similar meeting in 2018 with ASEAN and 2019 with SARC. So we are revitalizing this meeting, this collaboration between the animal and human health across the region. Yeah.
Aya, you have 1 minute.
Yes, one slide. The neglect parasitic zoonosis. So in 2018, we organized a tripartite bi-regional meeting to start discussing this foodborne parasitic zoonosis. And since then, we closely worked with FAO and OIE again, and with the HQ to develop a series of tools for control of this neglected parasitic zoonosis. Also, we are hoping to organize a regional tripartite webinar to launch these various tools at the regional level, but we really need to mobilize resources to support disease mapping and One Health intervention for this area. And for dengue, again, we have established a regional tag on dengue and other arbovirus diseases in 2021, and the next meeting is next year. And we are also closely working with WHO at WHE, the World Health Emergency Program, in headquarters and the regional level on the dengue risk assessment, outbreak response. Especially this year, we supported Nepal, Sri Lanka, and Timor-Leste, and also laboratory strengthening. And also, this is not limited to dengue, but we have also started supporting an integrated field entomology training at the regional and national level to enhance entomological and also integrated vector management capacity across the region. And finally, for skin NTD, we have occasional report, for example, the scabies outbreak from the Cox's Bazar in Bangladesh, but we don't have enough resources to support MDA or targeted intervention. So that has been the challenge. But
Aya, we cannot see the slides. Aya, sorry, we cannot see the slides. Thank you. Okay, thank you.
Yeah, so we are starting to develop the integrated skin entity package from next year onwards. And that's it. This is just for the reference. So this is the update from the CRO. Thank you very much.
Thank you, Aya. Excellent work. Who must be Western Wipro?
So the next one is Western Pacific region, and the presentation will be given by Dr. Sung-hee Kim. Sung-hee, you have the floor.
Good morning, good afternoon, everyone. This is Sung-hee. I'm a NTD focal point, WHO Wipro. I'm going to introduce some of the NTD perspective and updates from the last meeting in our regions. So we have 37 member states and territories, and out of 37, 28 countries and areas, around 15 NTDs endemic in the region, and there are yours, LF, cystotrachoma, STH, foodborne trematose, and Tenias cysticercosis, mainly with the menstrual administration, and also we have other parasitic zoonosis and other leishmaniasis, mainly in China, and Buruli ulcer and dengue and scabies and snake bites and venoming, altogether 15 diseases. Our work in the region is guided by the Regional Action Framework for the control of elimination of NTD in the Western Pacific, which was endorsed by Regional Committee meeting in 2018. The goal of the framework is to eliminate 6 diseases, yaws, LF, cysto, and trachoma, rabies, and leprosy, and also control 9 other diseases. So we have a proposed MDA and veterinary public health, WASH, vector control and care and rehab as a main strategy. And we have identified 4 strategic pillars to achieve the goals and contribute to the programmatic capacity and overhead system strengthening for member states that they could adopt this strategy. The first one is catalyzing coordinated multi-sector action. Second one is enhancing interventions and service delivery. Third one is engaging and empowering communities. And the last one is measuring impacts and generating evidence. So let me first update the progress mainly in 2020 on the elimination of lymphatic filariasis. Out of 22 endemic countries and areas, we have already achieved 10 countries for its validation of elimination by 2020. Most of them are achieved before the pre-COVID era. But fortunately, Laos has managed to complete the final task 3 and submitted the elimination dossier, which is under review by the Regional Dossier Review Group. We also have New Caledonia finally complete the LF assessment, and we adopt IDA very soon at the end of 2022. During the waves of COVID, even in 2022, we have 2 countries which were able to conduct IDA, which is Tuvalu and Papua New Guinea and East New Britain province, by engaging communities and enhancing effective MDA delivery. And this was facilitated extensive micro-planning exercises and adoption of revised height-based dosing in Papua New Guinea, intensive media campaign and social mobilization from the support provided by our partner, and health workforce training on LF transmission and IDA use, and also based on newly available WHO guideline on pharmacovigilance and strict adherence to DOTS and implementing coverage surveys. Next, disease is trachoma and yaws. For trachoma, we have already 4 countries out of 10 endemic countries achieved validation, and Vanuatu recently obtained validation of trachoma elimination. And ancillary survey indicated this conjunctival scarring in Melanesian countries, Vanuatu and Solomon, and possibly in Papua New Guinea, not associated with active trachoma, especially in Vanuatu. So based on the Vanuatu success, Solomon considers dossier development for trachoma elimination. Fiji is planning for ancillary surveys, while Vietnam already has convened dossier review group workshop for the dossier development. Another PC disease in our region is yaws. We have 3 countries endemic for yaws, Vanuatu and Solomon and trachoma. And this has been mainly implemented by integrated MDA, piggybacking other PC disease MDA by engaging communities and enhancing MDA surveillance and hygiene. And Vanuatu was able to complete the conduct enhanced MDA in 3 provinces, which is ongoing at the moment for high-risk areas of scabies and also for yaws in the integration with SDH deworming in 2021-2022. Solomon Islands currently conducts scabies MDA, and there is a planning ongoing for integrated yaws scabies MDA with Western Province in late 2022. And 2023 onwards, there will be intensified case investigation and surveillance and integrated community school hygiene and health education interventions. Next disease is schistosomiasis. As for the elimination of cysto, fortunately, over a few decades of MDA, we managed to cover school-aged children and adults in all endemic communities with 75% coverage. And we have very focal endemicity of cysto in those 4 endemic countries, and we aim for interruption of transmission by 2025. This is mainly managed by enhancing multi-sectoral cooperation. As for Cambodia and Laopedia, they continue to expansion of community-led WASH initiative to eliminate cysto in those endemic communities. And we also have operational research component for zoonotic transmission control in Philippines. The next is, so regional priorities for 2022 and 2023. For the PC diseases, first the LF, we plan to complete IDA in Samoa, Fiji, French Polynesia, New Caledonia, and PNG, West New Britain province, also the remaining 1 province in Philippines. Micronesia is due to conduct task 3, which have been delayed from 2019 due to COVID, and we newly plan to conduct the first post-population survey in Kiribati with the implementation of trachoma MDA together. Trachoma Vietnam dossier development is our main priority. Yaws integrate MDA as mentioned in Vanuatu, Solomon, and Papua New Guinea. For the cysto, continue to scale up community-led WASH initiative, and also we would like operationalize elimination surveillance. And as it mentioned during the CRO updates, we plan to have cross-regional collaboration for especially cysto surveillance and control activities. For the rabies, this is also another area for the cross-regional collaboration. We have created very strong network for WHO, FAO, OIE joint support, and usually for those 3 rabies endemic high-risk countries, we have supported stakeholder meetings and strategy planning, and also other tool development. And currently, division of ASEAN rabies elimination strategy is ongoing, and tripartite regional meeting with FAO and WAHO is being planned in 2023. For the disease targeting control, we continue to deworming and also other zoonotic diseases. Multi-sectoral collaboration is in highlight. For our regional challenges, limited human resources at regional level and country level, and also competing against other public health priority. Given the geographical challenges in the Pacific Island countries, the huge impact has been on logistic challenges. We have some problem. We have a big problem to arrange the donation of medicines such as azithromycin, also for some other diagnostics for yaws, because the plane availability and cargo availability has been decreased a lot, and limited funding for non-PC diseases are continued. but we are able to move to a new phase of ahead of WHO guidance and needing to move with operational research in the post-COVID-19 era. Countries are asking more specific guidance to WHO, and we're happy to able to provide specific recommendations based on their request, such as M&E and surveillance strategy, control of zoonotic cysto, and proof of concept for multi-sector intervention to control some of zoonotic diseases. This is the end of my presentation, and thank you very much.
Thank you. Do we have one more? Euro?
That's all.
No, that's it.
That's it. Okay. Well, thank you all very much. A lot of work going on. Very nice presentations. I think we should probably, we're a little bit behind time, so I suggest we move on to hear from our partners. And I think the first partner is the Schisto Control Initiative from Wendy.
Thank you. Oh, so sorry, just while the presentation is being put up, just to introduce myself. My name is Wendy Harrison, and I'm the CEO at the SCI Foundation, which is an organisation that supports governments to implement sustainable schisto elimination programs, and we have a 20-year experience working as a NGO and also in academia. So what I just wanted to share with you this morning, and thank you very much for the opportunity to do this, is really just how the roadmap has really guided what, and very importantly how we do our work. And so I just wanted on the next slide just to share with you a couple of examples of this. So if I could just go on to the next slide, please. Thank you. Yeah, so just really 3 case studies, I think, to illustrate how the mandate that we feel as an NGO we've been given through the roadmap and how we're implementing that. So if I could have the next slide. So the first one's just on the accelerating program action, as obviously we're very familiar with as the first pillar. And the example here is just around the Morbid project. So in summary, this is a large group of partners, primarily ministries of health and other partners who are present in the room here, really just to conduct a pilot project to identify the morbidity markers to guide program decision making. And again, as we're very well aware, there's a real critical need for this to meet. Oh, sorry, back one. That was the right one, sorry. There we are, thank you. And so, and the key findings from the study are that the data, and again, I've just shown a sample here on the right of the slide, that the prevalence of microhematuria could be a feasible indicator to assess elimination as a public health problem. And clearly the current indicator, which is less than 1% prevalence of heavy intensity infections, which obviously is reasonable when initially defined, but may not actually account for morbidity associated with light and moderate intensity infections. So the implication of this really is around having an evidence-based target for morbidity control will be able to importantly affect the use of donated drug, praziquantel, really ensuring that that's targeted and used in the most effective way, and will accelerate programmatic action and maximize the program's public health impact. And the research in this area is continuing. So could I have the next slide, please? So the second example is just around pillar 2 of the roadmap, intensifying cross-cutting approaches. And we've already had a number of questions and discussion around interaction with the WASH sector. And so here, supporting the Ministry of Health of Uganda, and again in a partnership model, we've conducted a pilot project, really looking at a community-driven understanding of what are the mitigating actions that are needed against the risk for schistosomiasis. And primarily that was around identifying high transmission areas and taking a very participatory approach so that it could necessarily be very context specific, and then engaging with a joint level planning, community action plans, and identifying what interventions were required. And what was very interesting around this project was that by assigning specific roles and responsibilities and having a really clear understanding of what was needed, the project was able to engender a lot of other stakeholder support and across a number of different ministries. So it really indicated that strong community and intersectoral collaboration engagement, but also making sure that there's real insight into the feasibility of the risk mitigation strategies that are developed is absolutely crucial. So then if we could just go on to the next slide, please, which is the third pillar. And actually, if you could just click through that, that would be helpful. Thank you. Which is a change in the operating model and culture to facilitate the country ownership. So for us, this really is throughout everything we do, because we see this as a really important how we work and ensuring sustainability through absolutely everything we do. And the example here is just in Burundi. Burundi had selected the most appropriate platform for the delivery of Schisto and STH, which for them was Mother and Child Health Weeks. The ministry themselves convened the group of partners, and over a 15-year period supported the annual distribution of praziquantel, delivering 80 million treatments. The ministry was able to increase their capacity, and we as an NGO partner were able to be very responsive to the requirements. So at the initial stages, we were providing financial support for mass drug administration, and that really has changed to a position now where at the request of the ministry, we have just supported a reassessment survey which allows them to optimize their treatment strategy and demonstrate the impact. And the implications of that is that the Ministry of Health themselves have been able to reach the EPHP target for 23, which is 2 years ahead of what was projected. So for us, again, this really demonstrates that country ownership and leadership, and the partners being very responsive to the changing requirements of our ministry colleagues is absolutely crucial for reaching WHO roadmap targets and broader SDG targets. So just very briefly, my last slide, if you could just, sorry, that just shows the EPHP being achieved, which is fantastic. And just on the last slide, we are currently, as an organisation, celebrating our 20th year of existence, which is very exciting, but also a really great opportunity to reflect on what we want to achieve going forward. And we're developing a new strategy, which will start in 23 to 28. And we have organised the whole organisational goals around the roadmap pillars, because we see these as the mandate that we have been given from our country partners, and we see this as absolutely crucial in terms of successfully achieving the roadmap. Thank you.
Thank you very much, Wendy. Very nice presentation. I think next we have the End Fund from Carol Kavuta, who I think is online.
Yeah, hi. It's nice to see everyone. I'm not sure if you have my presentation, but I'm happy to share. Okay, thank you. It's really a pleasure to be here today and talking about the roadmap and the NTD elimination goals. So today, I just wanted to share, please, the first slide, to spend a few minutes talking to you about the ARISE funding, which ARISE basically means accelerate resilient, innovative, and sustainable elimination of NTDs. Next slide, please. I'm sure a lot of you have heard about ARISE 1, and ARISE 1 was in response to the FCDO cuts that happened last year. And so ARISE is an initiative between three funders, Bill Melinda Gates Foundation, SIF, and ELMA. And what I'm going to talk to, it's about 100 million over 3 years. We've already been through ARISE 1, and many of you on this call have actually been the implementers of ARISE 1. So, and ARISE 1, as you already know, was really set to really cover MDA goals in countries where the drugs were just about to expire, given the withdrawal of the FCDO cuts. So my presentation today, which is actually the next slide, is on ARISE 2. And ARISE 2 is, here I have in parentheses about $65 million, but so far it's about $63 million. Hopefully from the NFUND side, we can be able to raise the additional $3 million to get us to that $65 million number that I have here. So next slide, please. So the ARISE outcomes and core principles are very much based on really support of the WHO roadmap and support for country-level elimination targets. So through ARISE 2, we are hoping that we'll accelerate progress towards elimination goals. We will increase, we'll also increase sustainability. And in this case, it's very much connected to what you see as the core principles, where for ARISE 2, the activities and also the programs are actually locally driven, country-centric, and are very much led by the NTD program managers. We're looking at having approximate investments where we look at having the countries where these 5 countries that are on my right, Ethiopia, Kenya, South Sudan, Burkina Faso, and Senegal, which are the 5 countries that have been selected for ARISE 2, contribute and also get proximate investments from those particular countries. In addition, we're looking to strengthen and extend beyond business as usual, because business as usual is good. And that's what has gotten us where we are. But if we have to accelerate progress towards elimination goals, and especially get there before the 2030 deadlines, then we have to do things a little bit different. So ARISE 2 is working to see, and we invite all of you to work with us in that piece of doing things a little different. And that's very much connects to innovation. So any innovations, I'm glad that I followed Wendy's presentation, any innovations that we can scale up so that we get to elimination faster are very much welcome, and we're looking to hear from it. We're looking at excellence in monitoring, evaluation, and learning, and this very much relates to the first bullet on principles, which is the locally driven and country-centric, as well as the core investments, because if we have to get money from government, then you have to very much be able to show the results that we are achieving, but also how those results in the larger scale, but also in a holistic manner, fit into the general health system. Next, please. So this is just a quick slide, and many of you may have seen this. It just goes into detail about the countries that have been selected for ARISE 2. Those are the 5 countries. And on my extreme right, you see the different diseases. So it's the 5 PC diseases. And in many cases where there's already a donor, so we're looking at NTD programming in a holistic manner and in totality. So in cases where other partners are already supporting, say, trachoma in Kenya, we're not looking to intervene in that particular area. But we are making sure that the conversations that we have are holistic so that we know exactly who's funding what where and where are the gaps where we can intervene. In addition, as we get closer to elimination, it's really important that we begin to think about post-validation surveillance. So that's something else that we're looking at strengthening through this, thinking through last mile supply chain, data integration. I believe at the beginning of this conversation, there was quite a bit about DHIS2 and how we continue to support the countries in terms of advocacy, because if we have to get proximate investments, but also get core investments, then the NTD divisions and also ourselves, we have to be in a position to engage the governments, and we can only do that if we have skills in advocacy. So that's, the slides are available. I'm not going to detail for each country, and I'll be available to answer questions that you might have. Next slide, please. I believe that's the last slide. So in this case, I talked about country-centric and the fact that these programs, the ARISE2 is actually driven and led by the NTD program managers in the 5 countries. And the role of us as the N Fund is really fund management. So our job as the N Fund is to provide the grants once the country NTD managers and the countries themselves has decided on the implementing partners. We will support to disperse the funds as needed. And these, in terms of the implementing partners, it could be a government wherever it's possible. It can be at national level. It can be at county level, at regional level, at state level. The funding can go to research institutions. It can also go to local, regional or international NGOs, with the idea that within where it goes to international NGOs, there's a plan to then transition by the 3 years to either the government or some local entities. As the N Fund, we're also serving as a branded law of orchestrating the collaboration and serving as a secretariat in convening what we call an advisory technical advisory group, an independent technical advisory group, which we normally call the ITAG, which is a group of about 10 people. And these are experts in the different areas that we've mentioned, so disease areas, as well as advocacy, health system strengthening. And these are the individuals that will review the country work plans. So each country will develop, and they're in the process of developing a country work plan, annual as well, a multi-year plan. So this group will review these work plans, and once they've reviewed them, then they will provide comments to the countries will revise those work plans, and those will then be submitted on to the donors for approval. And then we'll continue to provide an oversight that the technical activities are implemented within the same the principles of ARISE, and the approved work plans, as I mentioned, have sufficient data to guide implementation. We will provide oversight and consolidation of reporting, that's annually, quarterly, but more so as guided by the country and the implementers. And we'll continue to support national programs and local partners to be direct recipients of funds in the future. We're working on a capacity building plan that will help us work on a transition from what is international, mostly to local and national programs. And we will continue to provide communication, public affairs, and branding for the ARISE funding. In terms of where we are now, countries have submitted their FY22 fourth quarter, really this quarter, the calendar year work plans. And we're in the process, the donors have approved those, and we are in the process of working on partnership agreements. These are mostly focused on service delivery, so we don't have any gaps on MDAs. And by December, there will be full approval of the FY23, so the calendar year that starts in January, the approval of that. as well as an approval of a multi-year work plan that starts from FY23, so January of 2023 through to end of 2025. So I'm happy to take any questions that might be out there. Thank you very much.
Thank you very much, Carol. Very, very nice. I'm afraid we don't have time for questions. We're running a little bit late. So I will call now on Toko Puli to tell us about the work being done by Uniting to Combat NTDs.
Mr. Chair, with your permission, we give the floor first to Carter Center because we have to upload the presentation from Uniting to Combat.
Chair, do I have your permission? Okay, great. Okay, I'm Kashif Ijaz, and I'm the Vice President for Health at the Carter Center. So I'll, in the interest of time, I'm not going to use any slides. I'm just going to go through very quickly to give an update on guinea worm, river blindness, and a little bit about trachoma. So on the guinea worm side, as was pointed out earlier by Gautam, last year we reported 15 human cases of guinea worm globally, and this year so far we only have 6 human cases. So we are trying to reduce it further, so that we still remain under 15. The other thing is that in terms of the animal infections, we are also down on animal infections about 50% compared to the same point in time last year as well. So those are the two sort of main things. In terms of guinea worm, we continue to work on the diagnostic therapeutics, vector control, genomics, and environmental testing and behavior change related research to interrupt the guinea worm life cycle program approach, as well as from a novel research to advance the zero incidence. So I'm not going to go into detail, but if you look at the life cycle of the guinea worm, at every step of the life cycle, we do actually have research which is underway. In terms of onchocerciasis, what I'm really pleased to report is that at the most recent Uganda Onchocerciasis Elimination Expert Advisory Committee, which was convened in August of 2022, the Carter Center started to work in about 17 foci back in the 90s. And now, at that particular point in time, all of those foci were red, if you look at the map of the country in Uganda. And so now we do not have any more red areas of ongoing transmission. Liberia was reclassified as suspected transmission interrupted. And additionally, 3 foci have completed post-treatment surveillance and have also been reclassified as transmission eliminated. So the entire country is now dark green, which means elimination of transmission of onchocerciasis, or there are a couple of areas which are light green. So we are headed towards Uganda reaching the last mile in terms of elimination of onchocerciasis. The other, which is very exciting for everybody. On the Nigeria side, in 2021, Plateau and Nasarawa states, which were 2 of the states in Nigeria where Carter Center works, their transmission has been eliminated, and 5 additional states where we actually are working right now have also been reclassified. 4 of these states in Enugu, Ambara, Imo, and Abia, we are going to be conducting processing the flies to look at the entomological side of things. And if results are favorable, these 4 states will also qualify for stopping MDA. And then TCC, the Carter Center, is collaborating on remote sensing of black fly breeding site project with the Bill and Melinda Gates Foundation as well. And then lastly, one other thing that I need to point out is Carter Center's Onco Elimination Program for the Americas, helped eliminate river blindness transmission in 4 countries, which is Colombia in 2013, Ecuador in 2014, Mexico in 2015, and Guatemala in 2016. And these countries have also been validated by PAHO. The exciting thing about trachoma is after 22 years of work in Mali, we have now completed the final surveys and are moving to submit the WHO validation dossier that trachoma has been eliminated as a public health problem in Mali. Now, this is a country where there's a lot of insecurity, and our teams had been waiting and watching to have the appropriate safe time to go and do the trachoma impact surveys. And they quickly mobilized and spent 2 weeks in surveying the area, and thus formally ensuring that every single district in Mali has met the required elimination threshold. So this is something which is really very exciting. And this work has been supported through the Hilton Foundation for the last 22 years. And so that is, and then we are continuing to work in Niger as well for trachoma. So those are some of the very exciting news that I wanted to share with the STAG. Thank you.
Thank you. Very, very impressive progress. So have we got these?
UTC now, and Toko will be sharing her slides.
Okay.
Toko, you have the floor.
Hi, good afternoon. I hope you can hear me.
Yes, very well.
Excellent. So I'm going to just try and share my slides. I hope you can see that.
Yeah. Can you put them in presentation mode? Good.
Are they in presentation? Fabulous. Okay. Thank you so much. I'll just whiz through this very quickly and hope I can move along my slides, which isn't working at the moment. Okay, so whilst I'm waiting for my slides to move through with the presentation, I just wanted to focus on what Gautam presented this morning about the Kigali Summit on Malaria and NTDs, which took place in Rwanda on June the 23rd, and to share the key outcomes for UTC. One was the endorsement of the Kigali Declaration, which was designed to mobilize political support and resources in support of the WHO NTD roadmap. And one of our key outcomes was to ensure that we had this endorsed by countries and partners. So we were pleased with the launch of the Kigali Declaration in Rwanda by President Kagame, supported by a number of heads of state. And at the time of the Kigali Summit, we had 57 endorsements and 11 from endemic countries. So you can see they were really delighted with the countries that endorsed the declaration, and most of them endorsed it at the head of state level. So this gives you the breakdown of the different types of partners that endorsed the Kigali Declaration. You can see there Tawanda Hodza, an LF patient from Zimbabwe, who spoke so eloquently to the leaders about the need to address NTDs. But one of the things that we're really happy about with the Kigali Declaration, beyond the endorsement of the Kigali Declaration itself, was the fact that we were able to expand the commitment to NTDs by the 54 member states of the Commonwealth beyond a previous single disease specific commitment, which was for the elimination of blinding trachoma. So in the communique of CHOGM, you will see there was explicit mention of the WHO NTD roadmap and the endorsement of the Kigali Declaration as a commitment by the 54 member states, which really gives us good leverage to follow up with countries on commitments. And this CHOGM commitment builds very nicely to the G7 commitment, which was made at the last G7 meeting and the TICAD 8 conference recently to prioritize NTDs. So we feel very happy that across major political institutions, we have the roadmap and NTDs prioritized, and this really gives us a really good footing to move forward with. So I wanted to share with you the commitments tracker that we developed to support the Kigali Declaration. We were very clear that the Kigali Declaration wasn't a petition for which we were looking to mobilize lots of signatories, but it really was a deliverable tool used to mobilize commitments. So alongside the Kigali Declaration, we developed the commitments tracker, which is online and is a tool being used by partners to input financial health product policy and in-kind commitments in support of the NTD roadmap. So it's for period 2021 to 2030. This tool is for partners to go into the tracker themselves directly. So UTC doesn't enter any data, doesn't edit any data. It's a password protected platform where partners themselves state what their contribution towards the NTD roadmap looks like. The slide that follows shows what we had captured in the commitment tracker by the time of the Kigali Declaration. So $1.5 billion in financial commitments, 18 billion tablets donated by pharma companies. The 18 billion value does not include the expanded Pfizer extension, which was announced at Kigali Summit. So that will be added on later. But you'll see there the commitments by different stakeholders. And you can see that the one that we will be focusing on in the next phase is the one for national governments. We have several governments that have requested passwords, looking at the tracker to enter their commitments. We're really keen to have a good view of what countries are currently committing to NTD programs. So we hope over the next few months to be able to share this updated tracker information showing commitments by different stakeholders and more importantly by countries to NTDs. So this dashboard is the top line view, but we are working on with partners that have inputted their data on providing more granular data to partners, which I know you're all interested in. And we hope this will be a really important resource for the roadmap to understand where funding for the roadmap is coming from and what shape or form it's taking. So you'll be able to use the tracker and go in and search by organization and see how the commitment is broken down. So this gives you a snapshot of what that would look like. So currently, when partners go into the commitments tracker, they're able to say what disease they're committing for, whether that's across all entities, and what that funding is for, whether it's for specific interventions, for R&D, integration into health systems, technical assistance, advocacy, or for cross-sectoral activities, and where the funding is targeted. So at the moment, partners, for example, may not be able to say exactly which country the funding is going to, but in many cases, they've been able to say, this is going to Africa or Asia. So we're hoping that over time, we'll be able to drill down so that we're able to look at this data by country as well. So we hope to publish this commitment tracker by World NTD Day. Once we have everybody's agreement, particularly those making commitments that they're happy with their data being published in the way that we're publishing it. But hopefully for the STAG particularly and WHO, this will be a really good resource for you to see. So these are just some of the companies and partners. Some, for example, companies have expressed their commitments via tablets donated for pharma, and some have expressed their commitment in financial value, including where support goes to other partners in WHO. So it's really been interesting to see some of the data from companies, particularly that we haven't had access to before. In terms of what we're going to be focusing on next, so in terms of the cleaning of the data itself, one of the key things that we've been targeting as a team, and we're in a good place now, is avoiding duplication and double counting, particularly within the NTD community, where we have primary source funders, we have recipients of funding. So we want to be sure that in the data we're presenting, any recipient of funding where particular donors have also entered their own data on the system isn't duplicated. So that's really a big job, bearing in mind how many layers of program management and implementation there is in NTD. So cleaning that up has been really important. Also moving beyond aspiration to secured funding. So asking partners to reflect funding that's actually secured more than fundraising targets. And then the third piece is around representing partner commitments and ensuring that the categorization is correct, and updating the tracker system to accommodate unique multi-sector commitments. So currently we're working with the Japanese and the German government about how their commitment is reflected on the tracker So, for example, where funding for NTD sometimes comes from One Health or comes from other sectors, how does that get reflected on the tracker? So Agile, we're adopting it and adapting it to meet the needs of the unique committers so that we have as accurate data for NTD funding as possible. And then another follow-up is the donor roundtable, which BMZ is working with us on, mobilizing a European donor roundtable. We hope that will be in November. This would be another platform where we could mobilize additional commitments. And then we will be looking at communicating out the outcomes of the Kigali Summit and also sharing the commitments tracker. So the report of the Kigali Summit is done, is complete, and it will be landing in your inboxes soon. If you're not a current subscriber for UTC and wish to receive some of these reports, please get in touch, particularly some of the new fantastic staff members that may not be currently on our mailing list. I think I have, yeah. So this is, I think, my final slide on the next steps. So we'll be sharing the high-level dashboard with partners. In the next report for the Kigali Summit, we will be working on the partner profiles and consultation with partners so that you can read a little bit more about the profiles of the partners, public publication of the dashboard, which I've talked about, which will be on World NTD Day, country commitments on the tracker. We have a lot of interest from countries that are keen to input their data, especially when you look at the commitments of funding. So countries actually, when you show them on paper that we are currently reflecting commitments from donors and countries are missing, they totally get it and they're keen that they are reflected as well. World NTD Day will continue to be a commitments moment. So where some of the partners were not in ready to announce their commitments at the Kigali Summit, we'll continue to use World NTD Day as a moment to announce any new commitments that will come from partners. And then the ongoing work on accountability and tracking the commitments to make sure that they're actually delivered. One final one is that taking advantage of Rwanda's chair in office for the next 2 years as CHOGM, they're really keen to work with us to help us on the reporting of the commitments, which will form part of the CHOGM report. So I think that is my last slide. Thank you so much, and I hope I kept to time.
Thank you very much, Thoko. You did keep to time. Thank you. So we have 10 minutes before lunch. So there were some people with hands up before these last talks. Should we? Yeah. Indiwari, you had your hand up for a long time.
I just wanted to express some views on the diagnostics actually. It was in the previous discussion. Now we know that diagnostics are not widely available, and it is there is a difficulty in manufacturing. And most affected countries for these NDDs are the developing countries, and who cannot afford for this sophisticated diagnostics. And if it is not provided free of charge or as a donation, it's difficult for us to continue the diagnostics. So now because of that, these developing countries have adapted most of the time the microscopy. Most of the time for lymphodephilarisis, we are using microscopy, and for the others, STHs and all the leprosy, everything, we use the simple diagnostic strategies with microscopies. So we have a lot of human resources, but the funding problems are there. So I should, because I think Daniel mentioned that there is a movement for improving lab capacity and networking. So I wanted to suggest to include all these microscopic laboratory capacity enhancement and networking, because we have problems in identifying various kinds of parasites or the other infections when it is coexisting. So there should be an accreditation system or a external validation system for other countries to move on with to continue the current cheap diagnostic practices in our countries. So that is my suggestion for this. So the malaria program has such a kind of accreditation, so we can easily adapt the NTDs for those laboratories with parasitologists and all the other people. So that can be taken forward. Thanks.
Thank you. Would Daniel like to comment on that? So as I understand it, in Africa, malaria is mainly lateral flow assays, RDTs these days, rather than microscopy. Is that correct?
Yes, malaria, TB, and other programs have developed these external quality assurance systems. They have well-developed panels for doing that, and systems, manuals, etc. For entities, because of the variation in the programs and because of also the role of diagnostics in different entities, like the role of diagnostics in PC entities versus case management entities where you have to test to treat is different. So, however, there is now, that is one of the area the entity diagnostic technical advisory group is also planning to do. There is a subgroup called clinical diagnosis imaging subgroup, which is currently discussing how to enhance and support even microscopic diagnosis using artificial intelligence through remote, connections. That is one area. And then also how to develop external quality assurance system for NTD diagnostics and NTD programs, which can have or benefit from that. So that is currently a discussion underway.
Okay, thank you.
Thank you. Now, I see Rosa has had her hand up for a long time.
I would like to focus on leprosy. First of all, I would like to congratulate all the presentations, because despite the COVID pandemic, I think that a lot of progress have been made. And I would like to focus in leprosy because leprosy is a slow evolution disease, and 2 years missing diagnostic will be maybe the most impact of all the neglected disease. So I'd like only to recommend that the countries can be alerted by the damage of keeping leprosy in and not in priority because of the disabilities, and to try to bring back some strategies that were very good, like focus on active search, focus on the areas of high transmission, because in the roadmap, leprosy is targeted for interruption of transmission, and it's very difficult to achieve with the 2 years of missing diagnostic. I think that this 2 years of missing diagnostic will impact in achieving the target or for interruption of transmission. So I would like to focus on this, and more than ever to focus in integration approaches, like using the campaigns of STH, for example, or the other disease target for PCT, to include also leprosy screening. Like I think that in the skin entities roadmap, you have the recommendation of using the self-screening form. I think that we had experienced this in Brazil and in the past, and it worked very well. So I'd like to stress the importance of new tools of I think that in the roadmap, you have all the things like the point of care tests that are needed, and also something that I think that some PAHO advisor that mentioned was the single doses of rifampicin, that until now, not all the countries are using largely as it was recommended, as it in the in the leprosy recommendations. I think that Brazil, for example, the second country in number of cases not using single dose of rifampicin for post-exposition prophylaxis. And so it is, I saw in one presentation about leprosy, child leprosy and grade 2 of disability growing up, and it's very concerning. I think that it's a very, very a reason of worry. It's a situation, and so that's what I'd like to mention. That like to bring back from the past, for the old past of leprosy, things like focusing in areas of high transmission, focusing in areas of difficult access, geographic and social access, that these access are worse now after pandemic time. So I think this and focus on optimizing research, like including leprosy in the campaigns of PCT, MDA disease. It's possible to do with the self-screening form, for example, which is recommended in the skin disease. So that's the points I'd like to stress for leprosy especially.
Thank you, Rosa. Would anyone like to comment on that?
Yes, I think there will be a presentation also tomorrow on the modeling the impact of the COVID on the different diseases, which diseases are will be affected more. Definitely, as you said, I agree that the COVID pandemic has affected the detection of new leprosy cases. So we've seen a decline in the detection of in the incidence of leprosy cases. So definitely that will be the program. So the program needs to probably prepare mitigating and accelerating mechanisms. The integration is recommended in the WHO NTD roadmap, as well as the skin NTD, and also different countries are currently, like for example in India, the active case detection of post-caladar dermal leishmaniasis is coupled, is jointly being implemented with leprosy case detection. The two diseases, they mimic each other, and integrated detection has enabled to increase the detection of both diseases. So it's complementary. Now the NTD the skin NTD integrated framework is also launched. I hope countries will start to adapt it and implement it. So far, around 6 countries have started implementing, and they are observing improvement in case detection in leprosy. However, other than the skin NTDs, as you suggested, with other PC NTDs, also there is a possibility of integrating the screening depending on local epidemiological contexts. So that is, I think, what I would say, and we accept the comments. Maybe Sol, do you want to end?
Thanks, Daniel. Thanks for the intervention, Rosa. The only thing I'll add is just to talk a bit about the modelling in preparation. I think the session is this afternoon. The modelling that was done to look at the impact of COVID-19 related programmatic interruptions really focused on 7 NTDs. That's LF, Onco, STH, Schisto, Trachoma, VL in the Indian subcontinent, and Gambiense hat. And we haven't specifically done the modelling for leprosy to look at programmatic interruptions. And I guess that's partly because of the way that the NTD Modelling Consortium has been supported to work on specific diseases primarily. And probably also partly because parameterizing models for leprosy is very difficult because of the uncertainty in transmission. So I think that's work that probably still needs to be done. You may well be right that it would have affected leprosy transmission more than others, that won't be the conclusion that you hear this afternoon because we haven't yet been able to do the work. But I'd be very interested in your views on how we might best do that. And you talked a bit in terms of how to support programs that focusing on areas with high transmission would be good, other than going to areas where we're seeing lots of disease. If you have other suggestions for how that might best be undertaken, we'd be very pleased to hear them. I know Pemaraju would be interested in that conversation, Pemaraju from the Global Leprosy Program. Thank you.
Thanks. Wendy, your hand has been up for a while.
Thank you for the presentations, and it's amazing to see some of the progress. One thing I would recommend is actually when we see the regional presentations, they use a different system. For example, Afro presented starting with the indicators and PAHO with the impact of COVID and so on. It will be nice in the future just to have a structure for those presentations, and so that we can grab the most important things. Saying so, especially when we see the progress, it's just the big progress we see is both on this eliminated or eradicated, and also a number of people requiring intervention. It is trachoma, LF, onco, and it goes on. It's amazing to see that the STH is not really benefiting much. When you see the report from Africa, or the report from 2016, 2020, it's the decrease in people who are receiving intervention is only 2.6%. So, yeah, from that's 592 million to 578 million. So yes, there is an increase in population despite the elimination of some of the entities like onco, LF, and so on. So we're not giving mass drug administration for this. It means in most countries, actually, the mass drug administration for the population who needs mass drug administration for STH is increasing. So I think we need to really have a new strategy for STH, because we see that there is no almost any country who has eliminated STH and schisto. I think we need to really work on that. And the other thing I would like to comment is, especially when to see also when we see the proportion of people, number of people requiring intervention, even though it has been stated around 24%. In the Afro continent, it's not much significant. We see a lot of those changes, especially in the Eastern Mediterranean and the Southeast Asia and so on. But Afro is not really benefiting from that. So I think we need to really work on that. And one thing I would like to ask is, especially with these success stories in LF and onco, one of the challenge is, yes, securing drug for scabies. Is there a plan to shift the ivermectin from those programs to scabies, and especially from donors and pharmaceutical companies? And the other question I have is guinea worm eradication. I'm sorry if this is a silly question. Is there really a proven evidence, a transmission between human and animal? So just thank you.
Okay. Would anyone like to respond to those? So the ivermectin for scabies?
Okay. Well, I think as of now, the current donor of ivermectin, Merck, is not ready to extend its donation of ivermectin for scabies. We have reached to them, we have to talk to them, but as of now, they are not want to extend their beyond LF and onco. So that's the status, and that is why what we are trying to do is finding alternative low-cost, affordable ivermectin, which can be pre-qualified so that they are accessible to countries at low cost to at least buy. So, so that's the answer to your ivermectin. I think the rest of your questions need to be looked into, because some of the things the progress in Afro and other things, I'm pretty sure our Afro colleague could answer to that. But it's not just STH was never targeted for elimination in the first phase of the roadmap. The first roadmap, it was just to achieve 75% coverage in school children. And if you see that group till 2019, I think it was a good progress. And then because of the COVID, it got a hit, as others have had. So yeah, I do agree that there is a lot of support for some programs, and that was what also I concluded in my presentations, but not for all across the board, and that's something we need to work towards.
Okay, thank you. Time is going on. There's a hand been up down there for a long time. Jeff Warren.
Which one are you?
Thank you, Chairman. Actually, ILEP produced a 3-minute presentation, which evidently I didn't communicate adequately, but which actually addresses from the NGO perspective, some of the issues that Dr. Rosa has raised. So would you be willing for me to do that now?
3 minutes.
3 minutes
Yes,
it is.
3 minutes.
So for those that don't know, ILEP's a consortium of 14 international NGOs that are working in 60-odd endemic countries towards zero leprosy, by which we mean not just zero transmission, but also zero new disability, zero patients without treatment, zero stigma and discrimination. All these aspects are important for leprosy. And so ILEP members have, of course, as like other NGOs, embraced the WHO roadmap and more recently the Skin NTD's strategic framework. And these have got significant implications for the leprosy world and for ILEP's role in it. So, for example, under the heading of accelerated program action, ILEP members are continuing to support countries to take post-exposure prophylaxis or single-dose rifampicin to scale, but only among those countries that are willing to do that. And one of the things that we need at WHO to do is to continue to urge countries, based on the evidence and based on the fact that this is in the WHO guidelines, to adopt post-exposure prophylaxis. We're also supporting work being done by the Global Partnership for Zero Leprosy to develop target product profiles for diagnostic tests for leprosy infection and also for leprosy disease. Under the heading of integration, there's ongoing dialogue and frankly, sometimes debate among ILEP members about how best to integrate leprosy services with other skin ETDs. And from one point of view, it's obvious that there's huge advantages from the point of view of active case detection and contact tracing and mapping and management of disease complications and training and so on. But at the same time, we recognize that integration carries some risks for leprosy, risk of erosion of the leprosy expertise that's been built up over the years, which is important because leprosy is a difficult disease to diagnose and manage. Risk of overloading health workers, so that leprosy, which they don't see very often, just gets forgotten. Risk that leprosy is regarded only as a skin disease. So the importance of nerve function assessment for accurate diagnosis and treatment gets completely forgotten. And the need for instruction and disability prevention is overlooked. And there's also the risk of loss of focus for donors and partners committed to leprosy. Finally, on the topic of modelling of the effect of COVID, I realise that leprosy is not one of the diseases that's been modelled. But as Dr. Santiago mentioned earlier, we have a real problem. So leprosy new case detection dropped by 35% in 2020, and we all thought that it would pick up again in 2021, but it didn't. It only picked up by 5%. So it's still 30% below the trend line, and it was a very consistent, straight trend line. So that's about 140,000 people over the last 2 years that have leprosy, but have not been diagnosed and have not been put onto treatment. No wonder, therefore, that we now see a rise in the number of new cases of grade 2 disability on diagnosis, including children, and especially in the Afro region. So these are real concerns for us, which I bring to the STAG. Thank you.
Yes, thanks very much, Jeff. Absolutely, big concern. I think time for one more quick one before lunch. Kashif?
Yes, thank you. So two comments, and these are basically from our presentations this morning. One is when Gautam was presenting about the overview, one thing is related to the funds and the availability or non-availability of funding. I specifically looked at guinea worm just because we work on it, but I'm sure it's an issue for other entities as well. So my question back to WHO is, because I know that WHO's DG has been thinking about, having sort of block grants coming from the countries, and so that the DG has a lot of leverage in terms of allocation of funds. But which might be good for WHO, but there's a downside to it as well, which is because neglected tropical disease might get further neglected because of that particular approach. So that's one thing that I'm raising, but at the same point in time, I'm asking a question for WHO because in terms of fundraising, there is a development group at WHO which is supposed to be doing that, and I just wanted to get an update on where we are with that. The other thing I wanted to raise was in terms of the drug donations with the new SHISTO guidelines moving on from school-based to community-based SHISTO work. We recently had an International Task Force for Disease Eradication meeting at the Carter Center, which focused on schistosomiasis specifically. And this is a WHO recognized task force, and the proceedings will be published in the WER soon. But one thing that Dr. Waltz from EMERC actually raised was because of the change in guidelines, there's also been a change in demand in terms of praziquantel, going from like 236 million to 700 million doses. And then the big challenge is also going to be about the pediatric praziquantel as well. So I'm raising those things because I know that EMERC was going to work with WHO, as Gautam attended that meeting too, in terms of the eligibility and deciding on criteria for provision of praziquantel for treatment purposes for schisto. And so what's the timeline for that? And then in terms of the praziquantel donation, which I know is not the non-pediatric one, comes to WHO, but is there any thinking about the pediatric praziquantel, especially in light of the change in the schisto guidelines? Thank you.
Yes, thanks, Kashif. Any response from WHO to those questions?
Some quick response, I think, Kashif, regarding the funding. As you know, the current administration is more keen to get unspecified funding, and then it allocates to where the organization needs to fund these things. And this is an ongoing discussion with our colleagues. And in fact, there is going to be a session with what we call as the CRM and PRP, who allocate and raise funds for us with this tag. And hopefully these discussions will come up, and we hope to get a recommendation to the DG that NTDs need a stronger support for funding, both in WHO as well as outside. I think from the drug donation from the schisto, I think it's a little longer answer probably. I will just say at this point that as far as the donation part is concerned, as of now, again, what we understand and what we heard from Merck, I think Johannes is also online, is that their donation, and they're committed to the 250 million. We are not yet accessing the 250 million tablets. We are around 200 million, so there is a scope of increasing. The other thing, I believe that the technical guidelines should not be directed by the donation. I think there should be technical guidelines independent, based on science and evidence. And then whatever we get from donation, how we can access that should, we should launch the program. I think that's the approach the organization wants us to take, and we'll take. And we look for negotiating with existing donors, new donors, and also at the same time making medicines outside of the donation affordable in good quality. I would leave it at that. That probably answers your question to the pediatric praziquantel, again, I mean, it's a work in progress. We have no right answers right now, but yeah.
Okay, thank you. Well, it's been a fantastic morning. We've heard a lot of great work going on, but I think it's now time for lunch. So see you back here at 2.
Cafeteria downstairs. You probably can just go down the stairs and go to the cafeteria, because again, those who have been used to the old building, the cafeteria was different, but now it is just here next. That's the only cafeteria working in the whole building at the moment.
David, hi. Suggestion. You know, when we are on webinar, I have a suggestion. When we're on webinar, the chat is really quite useful for people to put their comments.
Yes.
Usually it becomes a lot richer because more people to speak. Is there a platform for this now, you think?
So who's going to look at the chat then?
Maybe we could respond later or whatever.
Yeah. Yeah.
To be able to take more,
Yes, the trouble is,
quite like that.